Morning, everyone. If you just hold tight for a minute, we're just getting everyone in. We're having everyone join us right now. If you hold tight for, as it says, hold tight. We will begin in just a moment. Thank you. Good morning, Anna. Hi, Julia. A donation link. What a great idea. Hi, Alexander. Yes, if everyone would like to put in the chat their name and where they're from, it's nice to know everyone coming in. Thank you. Tara from New Jersey. I'm impressed. Good morning, Odette. It's always nice to get your thank you each day. Hi, Napur. We can't wait till you start volunteering. Good to see you, Victor. So I think I should get started. I'm Kathleen King from Healthier Kids Foundation, and I have a little bit of housekeeping to do. I appreciate everybody putting their name and activity and where they're from in the chat. Thank you for that. There is a link in the chat for the agenda and packet. If you need to pull that up, it'll be in the chat. We're going to do our best to get through all the questions throughout the event. You may submit your questions using the Q&A. Please put it in the Q&A because it's a little hard to find them in the chat. And I'm often asked what the theme of our symposium is. This is Kathleen King again. We look for speakers that are motivating, thought-provoking, and want to pay forward with gratitude in all that they do. If you have a reason to express gratitude today, please share that in our chat also. I learned this start to a meeting from our chair, Mary Maben. Thank you. A reminder that the event is recorded. I would like to present who the sponsors are, and you can clap in silence for your sponsors. If you're an elected official, please put that in the chat as well. Our sponsors we'd like to thank are First Five Santa Clara County, Lucille Packard Children's Hospital, Silicon Valley Community Foundation, the Sang Castaneda Family, HealthNet, Santa Clara County Office of Education, Palo Alto Medical Foundation, Western Dental Kids, Gardner Family Health Network, Santa Clara Family Health Plan, School Health Clinics, Santa Clara County Dental Society, Michael Singh, San Francisco 49ers, Belair Strategic Advisors, Cadango, El Camino Health, Excite Credit Unions, Santa Clara County Social Service Agency, Santa Clara County District 4, thank you, Santa Clara County District 2, and I want to thank our staff, Laura Clandania, Rena Acapel, and Malika Sapon. And I know I didn't do your last names right, Malika and Rena, but I usually just call you by your first names. We are very fortunate to have Vice President of the Santa Clara County Board of Supervisors, Susan Ellenberg, here to speak about the state of the child in Santa Clara County and to introduce our keynote speaker. Vice President and Supervisor Susan Ellenberg represents a diverse population of just under 400,000 residents in District 4. which includes the unincorporated communities of Burbank, much of West San Jose, and the cities of Campbell and Santa Clara. Supervisor Ellenberg serves as the Vice President of the Board of Supervisors, as well as Chair of the county's Public Safety and Justice Committee, and the Vice Chair of the Children, Seniors, and Families Committee. Susan is a member of the California State Association of County Executive Committee and Chair of First Five Santa Clara County. Yahoo! Additionally, she sits on the board of Joint Venture Silicon Valley and the National Association of Counties Justice and Public Safety Steering Committee. If you hear me call Santa Clara County Kids County, Vice President Ellenberg is one of the reasons why. Vice President Ellenberg lives in San Jose with her husband, attorney Steve Ellenberg, and their two dogs, Lacey and Peaches. I think there's two Board of Supervisors who have dogs named Peaches, I believe. They have three young children, Zach, married to Ruth Ferguson, Molly, and Nava. I'd like to introduce Supervisor and Vice President Susan Ellenberg, a wonderful friend to all of us and to children.
Thank you so much for the lovely introduction. Good morning to everyone. Thanks, Kathleen and Laura and the entire team at Healthier Kids Foundation, as well as all of the supporters and sponsors of the Children's Health Symposium. As Kathleen noted, I'm Susan Ellenberg. I'm the Vice President of Santa Clara County Board of Supervisors. So to begin this morning, I want to take us back to 2017, before I joined the Board of Supervisors, when then Board President Dave Cortese led the charge on providing us with the first ever status of children's health in Santa Clara County, with encouragement and tremendous support from our own Kathleen King. That assessment provided a compilation of extensive data collection from residents and community partners. And from that data, 7 priorities were identified by our community as areas where we needed to step up supports for children and families. Since 2017, we've seen tremendous efforts by a wide range of partners to contribute to progress in each of these areas. And I think that it's a valuable exercise this morning for us to celebrate the wins, reflect on lessons learned, and identify continued gaps that we still must address. So we're going to begin with the priority of those 7 that is closest to my heart, childcare. Under the best of circumstances, with abundant resources, raising children is challenging. Imagine how much more difficult this task is for parents who are struggling to keep a roof over their children's heads while working through a system that is not set up to support working families. And on top of that, during a global pandemic. And I know that many of you here do not need to imagine it because you lived it. When I joined the Board of Supervisors in January of 2019, the county's direct interest, other than through CalWorks, in the childcare space was manifested through the Universal Access Pilot, which links children and their families in the Franklin McKinley and Alum Rock school districts to county programs, as well as early childhood education and childcare opportunities. Since then, it has been my #1 goal to remove barriers for all families wishing to participate in childcare programs. Prior to the pandemic, my colleagues and I worked hard to push administration to provide childcare options to our own employees. Santa Clara County is the 3rd largest employer in the county. Being able to provide this service, to me, should serve as an example and a model for private employers across the county. Our benefit is finally available through a pilot program that technically began in March of 2022 when the contract was signed. Employees received notice of the benefit and enrollment instructions in May. And in June, the Board of Supervisors will receive a status update on enrollment. During the pandemic, the county worked with Healthier Kids Foundation, First Five, County Office of Education, and local nonprofit and for-profit childcare providers to offer childcare for our county's disaster service workers at no cost to the county, at no cost to the employees. Costs were covered by the county. This work was absolutely instrumental in allowing county employees to continue to work during the height of the emergency by providing high quality subsidized childcare. I am very proud that we were able to provide this service to 273 employees and 424 children. But it's not just our employees who need childcare in Santa Clara County. The pandemic not only laid bare the need for childcare, it also unfortunately set us back considerably. Prior to the pandemic, many organizations and community partners who are here today worked very hard to increase access to childcare by advocating for waivers for our region, which has a high cost of living, more facilities for licensed childcare providers, worthy wages for our ECE workforce, and adding slots to serve more families. Because of the pandemic, and according to the data, thousands of childcare options have been shuttered. Even in Santa Clara County, with the pandemic relief assistance that has been provided, that three-legged stool that holds our ECE system for slots, facilities, and workforce has been reduced to nubs. Children unable to get into licensed childcare could suffer educationally and miss the stability of a safe, familiar provider. Unemployed or underemployed parents now have even fewer affordable options for childcare, potentially delaying their reentry into the workforce as California struggles to recover from the pandemic. Thousands of women of color who represent much of the childcare workforce are now out of work. Related to my children's roadmap to recovery referral, I asked my colleagues on the board, and they unanimously supported my direction to allocate $5 million toward the Quality Matters Workforce Pathways efforts. As many people here may already know, Quality Matters, a strong start for kids, is an initiative co-led by First Five and the County Office of Education. This program would include two components: early learning apprenticeships and a shared service alliance. In early learning apprenticeships, 25 apprentices will be hired by the California State Preschool Program employers, and 25 apprentices will be hired by family child care home providers with the agreement of a wage increase upon completion of the program. All apprentices will receive no-cost coursework through either Mission College or De Anza College and funded by workforce development funding streams. With this gap funding provided by the county, this collaborative will be able to launch a successful and ideally sustainable pipeline into the early learning and care profession, addressing the worrisome teacher shortage in our county and benefiting children and families for years to come. In partnership with First Five, the County Office of Ed, and other funders, Santa Clara County has also committed to investing in developing and establishing a shared service alliance across the county that will incentivize, prepare, and support the creation and expansion of family child care home micro businesses to meet demand for quality early learning and care. To recruit, support, and retain this emerging childcare workforce, the Shared Services Alliance will provide critical business and educational supports for the family childcare home providers. And finally, in this year's inventory process, I've asked my colleagues to approve a grant of $150,000 to First Five to support a family childcare home startup and expansion grants that will increase the availability of childcare. That item will come before the board during our workshops next week and for final approval in June. Let me move now to the second of the named priorities, which is housing stability. Housing, of course, continues to be one of the most pressing concerns for families across our county. And yes, the pressures became more acute during the pandemic. Oh, my light just went off. Hang on. Research has shown us that children who experienced homelessness as infants were more likely to experience health challenges, hospitalizations, and emergency department visits than children living in poverty who did not experience infant homelessness. Currently, there are approximately 600 families in our county experiencing homelessness, and another 600 new families enter homelessness for the first time every year. 75% of these families have a woman head of household, and 62% self-reported having children enrolled in school at our county. A wide array of supports was put into place during the pandemic by cities, the county, local philanthropy, and state and federal governments to stop evictions, provide housing stabilization funds, wage replacements for those needing to isolate, and assistance for back rent. During the initial wave of the pandemic, unhoused pregnant women were among the higher risk residents that were moved out of shelters and into isolation motel rooms. While this was a temporary support, long-term solutions must be implemented. So Last year, Supervisor Chavez and I led on an initiative to identify the number of unhoused pregnant women and families with young children and develop strategies for both immediate relief and long-term support. This effort culminated in the launch of the Heading Home campaign last October as a collective effort by the county, cities, and community partners to house all homeless families in Santa Clara County. To do that, we'll expand capacity to house 1,200 homeless families by October and then 600 more per year every year going forward. The goal here is to achieve functional zero by 2025, which means that there are fewer families falling into homelessness than we are getting out. So the 4 strategies, we're going to be leveraging about 1,000 emergency housing vouchers, which will provide rental support to currently homeless households for up to 10 years. We're expanding our rapid rehousing program, which provides time-limited rental subsidy along with case management, with the goal to serve another 200 unhoused families annually. We're expanding our homelessness prevention strategies to serve 2,500 households by 2025, and we're creating more affordable and supportive housing with approximately 1,000 new family apartments in development in the Measure A pipeline to be completed within the next 5 years. Food security is next. In Santa Clara County, more than 100,000 children live below the 300% of the federal poverty limit and may be experiencing food insecurity. Food insecurity dramatically increased during the pandemic, due both to loss of income for many families and the interruption of school meal programs on which so many families rely. We saw a scale up of response with incredible leadership from Second Harvest, dozens of community-based organizations, cities across the county, including, of course, the city of San Jose, and school districts that pivoted to grab-and-go meals for kids and their families. This massive mobilization was a credit to all our community partners, but it also made apparent the central role that schools and after-school programs play in feeding our kids. Second Harvest reported that during the last fiscal year, they provided food to approximately 500,000 people across Santa Clara and San Mateo counties every month, with a total of over 140 million pounds of food distributed, enough to provide 110 million meals. This is about double the pre-pandemic levels. Prior to the pandemic, just weeks before schools closed, I introduced a proposal with Supervisor Symposium to pilot a 4-year program for the county to fund the gap between federal meal reimbursement and the costs to school districts so that meals could be provided to all kids on high-need campuses. Instead, and fortunately, federal meal waivers allowed this model to be tested during the pandemic, with universal access allowed for federal school meal programs. So our county pivoted then to provide $1 million in supplemental emergency assistance to districts through the County Office of Ed. And then during the last legislative session, Senator Nancy Skinner introduced SB 364, the Universal Meals for All Act. And for the ledge followers in the crowd, it's now a 2-year bill that's active this session. And the governor added $650 million to this current year's approved budget to do exactly what our pilot proposed: provide state funding to allow for universal meals starting in the 2022-23 school year statewide, a first in the nation. Making sure kids eat at school is a benefit for their own health and academic performance, and it is a critical lifeline for the whole family, including younger siblings at home that count on school meals as part of the food budget for the family. Continued efforts to fund food access during school breaks and to maximize enrollments like CalFresh and WIC are critical to the health and well-being of all young children. I'll talk now about what I suspect is one of Kathleen's favorite topics: access to medical and dental services. Santa Clara County has been successful in creating high levels of health insurance coverage starting in 2005 with the Children's Health Initiative. In 2015, 90% of children in Santa Clara County had health insurance. And since then, expansions of Medi-Cal to undocumented children and youth have helped close that remaining small gap. In addition to recent state and county expansions that support the whole family, including preconception health and prenatal care for pregnant people, some specific advances for the health of parents and infants were approved this past year, including SB 65's Momnibus bill, which made great strides to close, which is making great strides to close health disparities and improve outcomes for all birthing people, including the extension of Medi-Cal coverage to 12 months postpartum and integration of a doula benefit into Medi-Cal. While Santa Clara County historically has very strong healthcare coverage levels, we know that access to care is about so much more than just coverage, especially given the pandemic impacts. Reports from providers indicate that many kids may have missed examinations and immunizations as parents have been cautious to go in for appointments. And healthcare providers have been strained by COVID, and many school-based screenings have been interrupted. In the near term, we will need to redouble our efforts to connect kids to care. Related to that is universal screening. And Santa Clara County has made universal screening a priority and has set a goal of ensuring that all Santa Clara County children prenatal through age 6 have access to routine prenatal, developmental, and behavioral health screenings with connections to early intervention services. Approximately 28,000 pregnant people and 10,000 children under the age of 6 should receive a formal health and developmental screening each year. Screening children for dental, hearing, and vision issues with a referral to specialty care is a cost-effective way to reduce negative impacts on a child's health and academic progress. Programs like the Healthier Kids Foundation have provided highly efficient screening programs for preschoolers and school-age children to identify needs and support families in connecting to care. This year, First Five, in coordination with the Santa Clara Family Health Plan, Anthem, and VMC, have partnered, is developing a model to expand developmental and adverse childhood experiences screening for families across the county. They've partnered with UCSF to apply an integrated model of care into well child exams to provide immediate connections to short-term behavioral health supports for kids identified with needs upon screening, and also to maximize the new Medi-Cal dyadic care benefit that allows for supports to be provided to parents and caregivers integrated with care for their young children. There's more to come as implementation of this model is planned for July 2022, including at the VMC Tully Clinic. We are moving through the 7 priority areas and now come to violence prevention. Over the past year, and with exciting developments in state investments in child and youth mental health, I have been very focused on expansion of school-based behavioral health supports and expanded access to care for children and youth to promote mental health and well-being. This is work, again, that I pressed for prior to the pandemic, and we've seen the needs increase dramatically as more young people have become disconnected from social supports and are experiencing grief, anxiety, and depression. I strongly believe that broader access to a range of wellness promotion and acute care supports on school campuses will reduce the impacts of youth suicide, interpersonal violence, and promote safe and supportive school environments. Despite the pandemic, our county opened a $6 million child advocacy center that serves as a sanctuary for those who have experienced child abuse. The center is now housed under our Center for Evaluation and Advocacy in our health and hospital system to help young survivors of abuse, assault, and neglect heal from their painful experiences. Staff at the CAC is trained to understand the impact of trauma on survivors of all ages, cultures, and religious faiths. The mission of the CAC is to ensure that each child is treated with respect and compassion during a very traumatic period of their lives. How we address this will determine how those young children heal. I'm going to say a few words as well about racism across our systems. We are taking great care to close the gaps in birth outcomes that are a result of institutional racism, bias in service delivery, and the cumulative health impacts of racism. Santa Clara County is home to the Black Infant Health Program, the Roots Families First Program, and the Perinatal Equity Initiative. And through my referral, again, with unanimous support from the Board of Supervisors during last year's budget, we expanded funding for these programs to broaden their reach and develop policy and system change plans jointly with our local hospitals and health plans. I am really grateful for the strong engagement of the Hospital Council and their members in this work. Additional efforts are underway with community input to reform our health system for patients and in our criminal legal system, including for youth, to address disproportionality and inequitable outcomes across systems of care. I've been very proud to be an ally to our community advocates and providers that have deep experience in addressing these issues, which you will hear more about shortly from Dr. Kofer. Finally, while I've touched on each of the 7 priorities and progress made in recent years, it is so essential that these issues are not addressed in silos. The issues of childcare, housing, food insecurity, health, and structural racism play out in interconnected ways. Families make daily trade-offs to address their needs in real time across demands at school, work, and home, and we've seen this more clearly than ever during the pandemic. Placing services in settings like schools and childcare centers where kids and families have trusted relationships improves access and reduces stigma. Coordinated outreach on food and housing jointly help us reach families that will otherwise be missed. We all have opportunities to make sure the ways we provide support are synergistic and reinforcing and responsive. The most essential change we need to make as organizations and providers is elevating the voices of children, parents, and caregivers as experts in their needs and experiences. Too often, across a broad range of services, we treat families as recipients of care and supports. If we are really committed to improving outcomes, promoting equity, and building trust, we must address the policies, presumptions, and institutional structures that disempower parents, youth, and caregivers as the most critical participants in any system of care. And finally, I'll lift up the hard work of Healthier Kids Foundation and all of our children's champions to continue to create meaningful change for our children and youth. There is still so much work to be done. The more we listen, respond, and align our systems to the experience and needs of families, the more we can achieve together. It is now my absolute pleasure to welcome the keynote speaker this morning, Dr. Flojan Kofer. Dr. Kofer is an epidemiologist who serves as the Senior Director of Policy for Public Health Advocates. She leads health equity initiatives focused on California state policy, boys and men of color, community-based 911 response, transgender health, youth trauma prevention in cities, and student wellness in Boyle Heights. Her professional interest is addressing emerging and persistent public health challenges through research, policy, and community engagement. Her work primarily focuses on public health prevention and restorative justice. Prior to joining Public Health Advocates, she led the Preconception Health Initiative for the California Department of Public Health. Dr. Kofer received her bachelor's degree in chemistry and women's studies from Spelman College. Her public health training was done at the University of Michigan School of Public Health, where she earned a master's in public health and a doctorate in epidemiology. She's an alumna of the California Epidemiologic Investigation Service and the Nehemiah Emerging Leaders Program. Dr. Kofer has served on local boards, committees, and commissions, including the Active Transportation Commission, Mayor's Commission on Climate Change, Sheriff's Outreach Community Advisory Board, Board of Directors for Girl Scouts Heart of Central California, and chairing the City of Sacramento Measure U Sales Tax Community Oversight Committee. She also hosts a local political podcast called Voices River City. For her professional contributions and community participation, she was awarded the Young Professional of the Year Award by the Sacramento Urban League, the Exceptional Woman of Color Award by the Sacramento Cultural Hub, and the 40 Under 40 Award by the Sacramento Business Journal. I am so excited to learn from you this morning, Dr. Kofer. Please, all of you, join me in welcoming this morning's keynote speaker.
Thank you so very much. I'm going to go ahead and share my screen. And I just want to say, I was really totally like geeking out as Susan, as you were, giving your presentation, you were speaking all of my love languages. I like to talk about there being work love languages, and included in my work love languages are people talking policy, connecting policy to the real and material conditions that our communities are experiencing and talking about where we are and where we need to go. And so I just really want to thank you for that really wonderful opening to this event today. And I am excited to have the opportunity to be able to zoom out a little bit and talk about adverse community experiences. I really enjoyed that so much. And I almost feel a little bit bad about zooming us back out because there were so many great details that were shared and so many of the solutions that I think we're going to allude to towards the end of this presentation. But I also think it's really important that we know the why we're doing what we're doing, and we're really thinking about our frameworks, because sometimes we can have the best of intentions, but if we don't really understand the history of what has happened and we haven't really appropriately contextualized the circumstances in communities, then often the solutions we come up to are misguided, and they are misaligned with what's happening in the community. And so then we end up making some progress, almost accidentally, but then we end up really harming ourselves in the long haul because we're not really addressing what needs to be addressed, and we're overlooking the major issues that are facing our communities. And so that's really the purpose of this presentation, is to take us back and really think about what is happening so that when we're drawing up our solutions, we keep that in the back and at the forefront of our minds, and always in the back of our minds, even when we are coming up with our policy solutions, which is something that I do on a day-to-day basis and love to do. So with that said, we're going to jump in and talk about adverse community experiences. So I like to start my talk by hopefully connecting with everyone by talking about the life course, right? So from, essentially conception for this person, because we want to think about, his parents' experience during pregnancy and what impact that had on his conditions of early childhood, and then going all the way through his demise. And the purpose of thinking about it this way is that Anakin from Star Wars, who becomes the primary villain in the first series of movies in Star Wars. And I think it's helpful sometimes to examine how common some of these themes are, that they even show up in fiction. And so in this case, we are going to walk through the life course of Anakin Skywalker as he goes on to become Darth Vader and better understand exactly what's happening with him. So when we think about his conception and his birth, he's born a slave, and there's no mention of another parent at all. And so we can kind of understand what may have been experienced during his mother's pregnancy, given the fact that both he and his mother are enslaved to the state at the time. And then throughout his childhood, he remains a child slave, but he's taken to be trained as a Jedi at around age 10. And as a result, he has really significant, abandonment and heightened arousal, and a really significant fear of loss. And it's really important that we mention this because on one hand, it's really easy to think about, him being taken to be trained as a Jedi as a positive, similarly to the way that children who may be experiencing child protective services or foster care were potentially placed because of a duty to protect, and because the conditions of their home were not safe for them to continue being there. But we also have to recognize that even when we're doing things in someone's best interest, that there also may be significant trauma to that separating families is not just a talking point about what happens when it comes to, immigration. It's also a talking point that we need to have about the families that we separate through intervention, even in their best interest. And so recognizing that is important to understanding what happens in his life and that heightened arousal and that significant fear of loss. When we get to his adolescence, right, this is the first time we really start to see some major protective factors that we are able to identify, and that we have, robust literature to be able to support having a trusted adult relationship and its impact on lifetime wellness. Also getting a Jedi education, and again, that impact on lifetime wellness and overall health status. And he's freed from slavery, which again, I would hope I don't have to convince, certainly not this audience, is a net positive and an objective good. And yet at the same time, because his education is tied to being part of the Jedis, he's now exposed to violence via the Clone Wars, really upfront, not just the violence of there being a war, but him being a primary actor in that war. And he has ongoing family separation because he and his mother have still not been reunited, and that really does haunt him throughout his adolescence and even his adult life. And so by the time we get to his adulthood, it looks a lot like we might expect for someone who has more risk factors than protective factors. He lacks trust of the people around him. Most of his primary relationships are not particularly healthy ones. Sith Lord Sidious is not someone who I would think of as, being in a healthy relationship with anyone. He has an unplanned, twin pregnancy. Spoiler alert, that's Luke and Leia. The movies came out like before I was born, so I don't even know if I need to say spoiler alert, but I'm going to anyway, because there's somebody out there who's furious with me, I'm sure. He has domestic violence in his marriage to Padme. He is severely burned. The Death Star explodes, and there's ongoing war around him, and then he prematurely dies. And so for those of you who've seen the movies, you may be thinking to yourself, wow, I never thought about Anakin's life quite this way. You also, those of you who are pretty big Star Wars fans, may be saying, I'm questioning that last point on the slide. The premature death feels like maybe you're trying to oversell this. But if you remember the end of episode 6, you'll notice that there was the actor who was supposed to be the unveiled version of Darth Vader was presented as a person who was, of traditional old age. And yet, based on the scrolling text that passes at the beginning of every movie, that person was only supposed to be 45 years old based on the chronology of the story. And so I bring that up for 2 reasons. One, I think it's just one of those things that George Lucas probably didn't pay much attention to in terms of the chronology of the story. But it works for us because of Arlene Geronimus's work around weathering and the idea that people who experience a lot of toxic stress and a lot of the weathering conditions of major risk factors throughout their lives actually appear to age faster than their chronological years because their telomeres shorten. And so their cells are actually experiencing a rapid cell replication over time because they are so stressed because of the conditions in their lives. And so that's certainly something that we see play out even in this fictional story. But the other thing that I think is really important for us to recognize is that this story is told originally. We started in episode 4. So Darth Vader was already a fully formed, what we would describe as a movie villain. And we spent three movies and then the better part of 3 decades wondering and hearing just little glimpses of how that came to be. But we did not meet young Anakin until almost 30 years later when episodes 1, 2, and 3 came out. And so we were left to ask ourselves, how did this happen, right? The same questions that we should be asking ourselves when we meet adults who are experiencing often the consequences of their childhood traumas. And instead we say, what's wrong with you? Instead of what happened to you. We don't remain curious about the things that have happened in their lives. And normally that's where I would stop, but I think it's really important for us, especially when we are moving beyond just the framework of adverse childhood experiences. So a very individual experiential model of what happened to you and what some of the health outcomes are that I'll talk about a little bit in just a moment, because I know it's gotten a lot more popularity lately. But we also need to move beyond just that frame to thinking about what are the system influences. And so if we, again, go back through Anakin's life, we can look at the local political systems, and we can look at labor and childcare and education. The idea that his mother's best option for him was basically for him to get a militarized education, which exposed him to violence and put him on the front lines of war. The role that the military played in intergalactic, galaxy politics, right? The environmental politics. What happened when the Death Star exploded? Was that the galaxy's version of Chernobyl? What is the fallout from that in terms of the health status of people who were living, nearby? What was the healthcare situation like? I mean, it's very clear that, the Darth Vader had chronic obstructive pulmonary disorder. I mean, the heavy breathing, the fact that he could not survive without the mask after he was so severely burned, like all of those things are leading us to have pretty significant questions about what happened to him and what were the system influences that led to this. So this is not just an individual story of Anakin, it's the story of how systems shaped his life and led to the confluence of protective and risk factors that he experienced. And so that's really the story that we need to focus more on, because so often we tell these individual stories and they are incredibly important. We need to know who people are individually, but we also need to realize that they're influenced by systems, and systems are designed and maintained by people. So when we're talking about trauma, right? Trauma, I think, needs a definition. And so there are just a few times in this presentation where I'll stop and define things, because colloquially, I think we have an idea of what trauma means, but we want to really be specific here about when we're talking about traumas. So this is an event or a series of events or a set of circumstances that are experienced by someone as physically or emotionally harmful or life-threatening, and they have an adverse effect on their functioning, their mental, physical, social, emotional, and spiritual well-being. And so when we begin to think about these traumas, we are often brought to a concept known as adverse childhood experiences, right? These traumas that occur prior to someone turning 18 in that early childhood as well as the adolescent timeframe. And recognizing that when we think about the life course, there are certain periods in the life course where experiences or events are far more impactful, both because of just your overall development and also because of the outsized impact that they may have on the trajectory of of your life. And so we know early childhood and adolescence are 2 of those periods. And we also know that pregnancy and childbirth is another one of those periods. And so what we found in the original ACEs study and the work that's happened that has been built upon its foundation is that people who experienced abuse, neglect, and household dysfunction, and certainly the measures have expanded far beyond the 10 that were in the original ACEs study to include things that some of the other traumas that may be experienced during that time frame, but that those people who experienced those things were more likely to have behavior, physical, and mental health outcomes, adverse outcomes in adulthood, and that there was a dose-response relationship. So the more adversity that people experienced during that early childhood and adolescent timeframe, the more likely they were to experience poor outcomes in their adulthood. And so that was an important finding in 1998, which was 24 years ago. That was an incredibly important finding because it was the first time that we had connected things, especially things like diabetes and heart disease, to experiences that were not related to diet and physical activity and genetics. It was the first time that we connected it to a person's lived experience beyond just talking more broadly about stressors, but talking about traumas as a very significant type of stress. But then we realized that even in expanding those initial ACEs to include things that were omitted from the first study because that study was done in Kaiser, and so everybody had health insurance and nobody was experiencing homelessness, and the population was disproportionately white and disproportionately middle class and mostly employed, right? And all of those kinds of things, even when we added in things like foster care or juvenile justice involvement or other traumas that occurred, death of a parent or a loved one, all these things that were not included in the original 10, we were still missing out on the contextual factors, the things that may not be happening specifically within your home, but that are still having an impact on you. And so that's where we really began to think more broadly about adverse community experiences and thinking about community trauma. And so community trauma here are when members of a collective are subjected to a horrendous event that marks their group consciousness and shapes their memories and changes their future identity in fundamental and irrevocable ways. And so that is the next part of understanding the traumas that people experience, because these are not things that are necessarily happening in your home, but they're certainly having an impact on what you're experiencing and how you're moving through life. And they also can have an impact overall on your health status. And so in addition to thinking about ACEs as adverse childhood experiences, we also now want to think about ACEs as adverse community experiences. And this is where we think about the communities and the institutions and the broader societal context and how that relates to behavior, physical, and mental health outcomes. And we see very similarly that those adverse community experiences, especially those that are long lasting and persistent, those that are not maybe discrete events, have a really significant impact on people's health and well-being throughout their lives, and especially moving into their adulthood. So when we begin to think about this, the underlying, reason for this is that there is stress, right? That the trauma that we're experiencing creates a type of stress that is toxic to us, a toxic stress. But recognizing that stress in and of itself is not the problem, right? We have positive stress. I certainly know I'm always nervous when I'm getting ready to do a presentation, no matter how many times I speak before audiences, or now I can speak in the comfort of my home, and I'm giving a talk that, I'm very familiar with, and yet I'm still nervous. But that positive stress goes away when I see the faces of the people on the call, and I am able to really get into the zone of walking through my slides and telling my story. And then there's tolerable stress, and that's when you have, some ability to recover from it, whether that's because of the social support around you or because the dosage of adversity is short-lived and you're able to recover. But the toxic stress, that is the prolonged activation of the body's stress response. And it's the part that doesn't go away. And that's the part that is particularly dangerous and damaging to us, because we're not designed to be in toxic stress. We're not designed to have prolonged activation of the body's stress experience. And so a good example of this is, if we think about the science of stress and how our hypothalamus, is activated, and we go through this cascade of experiences that activate our cardiovascular and immune systems. But then there's this feedback loop to the hypothalamus that tells it to stop releasing CRH and tells the pituitary gland to stop releasing ACTH and tells the adrenal glands to stop releasing cortisol so that we can go back to, our homeostasis. We can go back to our starting point. The challenge here is when we don't get that feedback loop because the stress doesn't go away and our bodies are not designed to be in an activated state all of the time. And that's when we start to have dysregulation, because if this happens constantly to us, our bodies begin to say, okay, these are the conditions we live in. How do we adapt? And that's part of what happens also in the brain, is that especially a developing brain has gray and white matter, and it's going through this process of neuronal pruning. It's one of the reasons why when you're learning a new task, it can be very difficult for you and you're spending a lot of time focusing on it. But once you do that task all the time, I'll take driving as an example. When you first learned to drive, you paid attention to everything, hopefully. And you were going through and you were checking your mirrors and doing all these things. And I'm sure if you've been driving for more than 5 or 10 years, you've had the experience of getting to your destination and not remembering any of the ways that you got there. Or you've been on what we call autopilot and accidentally gone to a place that you're so used to going. And so those are examples of the ways that your brain neuronally prunes, so that the tasks that you do all the time take less energy from you because your brain is trying to figure out ways to maximize efficiency. Unfortunately, the same thing happens when you have chronic stress, is that your brain then begins to figure out, okay, this is what we live in. How do I help you to be able to efficiently as possible function? And unfortunately, those things can be maladaptive in our society because they show up in ways that don't necessarily allow us to be able to function and to be able to have the things that are necessary to survive and to promote our well-being. So part of what we also want to talk about here is, when it came to the pandemic, we kind of heard this refrain, right? That we're in this together. And I would say, sure, but similar to the Titanic, right? Which is literally a sinking ship. We saw that being in a sinking ship together did not mean that we were all experiencing that sinking ship in the same way. So if we look at the passengers on the Titanic, more third-class passengers died than first-class passengers. Men died more than women and children. And so if we look at those intersectional identities, first-class women were the most likely to survive compared to third-class men. And that speaks to a lot of what I want to talk about in terms of adverse community experiences, which is the intersectionality of these identities and how we're not all experiencing the same things in the same way, and that there were policy decisions that were made, even on the Titanic, to decide who got access to the limited lifeboats, who was loaded in first, whether or not those lifeboats were going to be completely full when they were sent out. All of those were decisions that were made, and they impacted people based on who they were and where they fit inside of society's constructs to determine whether or not they lived or died that night. So when it comes to COVID, a very similar thing has happened, that we saw the dual pandemics of COVID-19 and structural racism compounding the harm that was experienced by especially people of color, Black, Latino, Native Hawaiian, Pacific Islander, and our indigenous communities. And I'm using Sacramento data because that's where a lot of my work is centered, but certainly many of these patterns were replicated throughout the state and throughout the country. And so it brings us to a need to have a focus on the social determinants of health, right? These conditions in the environments where people spend most of their lives, where they're born and live and learn and work and play and worship and age, that then affect a broad range of their health, functioning, and quality of life outcomes and risks. And so they often operate in these 5 domains, thinking about their economic stability. So how much money do people have to be able to maintain their livelihoods? Whether or not they have access to education and the quality of that education, whether or not they have access to healthcare and the quality of that healthcare, what their neighborhood and the built environment around them looks like. And that can be very specifically to the air quality and to the water quality and to whether or not there's tree canopy and whether or not there's public transportation and what the community looks like and what's experienced in that community. And then there's the social and community context of what are you experiencing in your community? Is there a connectedness to the people there? Are there things that bring your community together? And also, what are you experiencing in terms of outside stress and or oppression? And so we understand that the conditions in our environment are shaped by policy and systems. And so the result is that we have communities that are often worlds apart. Several years ago, the California Endowment did a really great campaign where they talked about your zip code should not determine your life expectancy, and just showed neighboring zip codes where the life expectancy difference was up to 20 years for babies born in either of those communities. That's not something that's natural, and it's our responsibility really to figure out how to address that. And so it brings us to really understanding what we mean when we say a health inequity, because differences in health can occur for a variety of reasons. But when we're talking about health inequities, we're talking about systematic and unjust differences in health and illness that are often based on on someone's membership in a group that's been oppressed with historical and ongoing restricted access to resources. And this is not something that's occurring because of natural variation. This is something that we're seeing in a patterned and very predictable way. So if someone were to say to me in 2018 that in a couple of years there would be a pandemic, and this pandemic would be, a respiratory illness that would spread quickly among, populations, and, all of the kind of details we know without naming it. Somebody had told me that in 2018. I could have predicted with probably eerie accuracy exactly who was going to be most harmed by that virus, because I understood the patterns that already existed. And so COVID did nothing new in terms of who it hit hardest and how it impacted us. It just laid bare for us all of the existing and underlying risk factors in our communities, and it targeted exactly who any of us who had ever been asked would have been able to predict. And so that's an example of a health inequity, because it's being built on top of something that a pattern that we already put in place that was designed by people and by systems. And so one of the patterns that I want to talk about today is the role of institutional racism. And I want to talk about two particular policy decisions that have had a myriad of consequences for us that continue to proliferate to this day. But I want to first acknowledge that similar to that intersection of men and women and first and third class passengers on the Titanic, that the intersections of our identities are quite vast, that we have all of these different domains that comprise our identity. And so it's very easy for us to think about the identities that we most closely align with. Often those tend to be our one down identities, but not exclusively, but also recognizing that we have lots of identities. And so someone who may be privileged in one or two of these may have disprivilege in others, or vice versa. And so that means that you are having a very different experience than someone who has a lot of one down identities as defined here, or a lot of one up identities. And we need to just be really clear about the fact that everybody within, one category is not experiencing it the same, because it's colored by all of the other categories. So this is the second time that I'm going to do just a little bit of definitions, because I think this is an important place to stop and really hone in on what we're talking about, because the term racism is thrown around a lot. And we have had, conversations on the national stage asking, can babies be racist? We have had conversations about critical race theory. And I often find myself wondering, if I narrowed, pinned everybody to the wall and said, define racism for me, define race for me, what do you think we're talking about? I think we'd have very different definitions, because it's one of those things that I think we all have a colloquial definition of. We think we understand what it is, but it's a lot more nuanced and more complex than I think is often given credit. And so for that reason, I want to define it for us today. So this is kind of adapted from Kamara Jones' work. Dr. Kamara Jones was the former president of the American Public Health Association, and is just a renowned physician and public health expert, and really has done a good job of being part of the public health education on key risk factors, including things like racism. And so starting, there's personally mediated racism. And I think this is where a lot of people's understanding of racism stops, because this is the common way, the common parlance of like how we describe racism. It's when an individual actor does something incredibly awful to someone because of their race or ethnicity. And we go, stop, that's bad, you're racist. We don't tolerate that here, right? We're thinking about the individual acts. We're thinking about insults. We're thinking about, the things that we can kind of wrap our heads around and go, nope, that's a problem. And Nope, that's a problem. And we need to certainly address those because, as I've mentioned already, and we'll probably say several more times, systems are designed and maintained by people, and every level of racism sustains racist systems. So we certainly need to be thinking about the personally mediated racism. But if that's where our analysis ends, we miss out on understanding some of the other ways that racism plays out. There's cultural racism, right, which determines which group qualities and characteristics are valued or devalued. And the best example of that is to think about colorism, right, worldwide, in that there are only between 5 and 12, depending on how you define it, countries on the entire planet that were never colonized by a small group of countries in Western Europe. And people from that small group of countries in Western Europe just so happen to be light-skinned, light-haired, and light eyes, more so than most of the rest of the world's population because of their geography. And so in colonizing most of the world's population, that's now become a beauty norm that is seen across multiple cultures, even when almost no one in those cultures would look that way. And that is because looking like the people who are in power, right, who have colonized your space, comes with social and economic opportunity. It comes with social and economic privilege. And so it has become a beauty norm because it became a social standard because of colonization. And so that's an example of cultural racism. There's actually nothing wrong with being darker skinned or darker haired or darker eyed, but we've decided that that's a net good because of who's in power and because of the value that comes along with being more like the people in power. And then there's internalized racism, right? And so an example of internalized racism is stereotype threat, where we see sometimes, especially in the US context, Black and Latino students, if they are in study situations and are asked to report their race or ethnicity before doing a task, they perform worse because of the stress response that occurs in them, because they're worried that if they don't perform well, it will reflect negatively on other people like them, because they're aware of the stereotypes that they don't perform as well as their peers. And so that's an example of internalized racism, of accepting some of the messages about your race or ethnicity that are negative, and then questioning your own abilities and your own worth, and feeling an added pressure of having to prove that you are somehow different, or having to overcome stereotypes that were unfairly and inaccurately generated in the first place. And then lastly, right, the mother lode, which is institutionalized racism. And this is where we get into the discriminatory race or class-based policies or practices. These can be formal or informal, but this is the way that this is baked into how our institutions operate. And so the informal can show up in any type of ways, such as hiring practices and things that we do that can root people out and not give them opportunities to be part of the institution and make some of those decisions. And they also can be overt. When we have had policies on the books that say this type of person can't do this type of thing. And so I want to talk about this one because, again, systems are designed and maintained by people, and these reinforce each other. And so it's really important for us to understand both the impact of some of the policies that have been passed and also what happens when we don't do anything about them after we get rid of them. So the first example I'm going to talk about today is redlining. And redlining was the official practice of the Federal Housing Authority from 1934 to 1968, wherein they gave neighborhoods a score. So some neighborhoods were green, some were blue, some were yellow, and some were red. And they were defined, the system that was a hierarchical system. So green was best, blue was still desirable, yellow was definitely declining, and red was hazardous. And it really was a system based on white supremacy and proximity to Blackness, because the Green Line communities were intended to be entirely white communities. And it was recommended that businesses be placed there, that mortgages be backed there, that even things such as the tree canopy be maintained in these Green Line communities. And then the blue communities were considered still desirable because they either had a population of people who were not white, or who were seen as lower class or lower status. And so depending on what year we are between 1934 and 1968, having a large population of people who were Catholic or Jewish, or could possibly turn a Green Line community into a Blue Line community. The yellow communities, the definitely declining, largely had other people of color, or they had people who had less means. And so the combination of those was what kind of defined the blue and the yellow. How many and where and how close are you to a red line community? But red line communities were largely designed to be able to house Black, Latino, and Indigenous folks. And those communities were the places where mortgages were not to be backed, where you were not to place businesses. They were seen as hazardous. And I like to point out to people that the original Build the Wall movement was actually redlining, because we have a colloquial statement in popular American culture known as the other side of the railroad tracks. And in the documents for the FHA, one of the things that they recommended is that if there was a green line community that was planned to be in close proximity to a red line community, the suggestion was to separate those two communities by some sort of barrier, railroad tracks, a freeway if you could. And so you often see that there are these communities that are separated, that a freeway was run right through the middle of them, or if neither of those were possible, to build a wall. And so this is, how we started, our official housing segregation. We put it on the books during a time when, the GI Bill was expanding, when we have baby boomers, the largest generation ever in our country has been born. And so this is the landscape that is happening at a really pivotal time from 1934 to 1968. And so the legacy of redlining, right, is that 50 years later in 2018, 4 years ago, we saw that 2/3 of those redlined areas are still inhabited primarily by Black and Latino families, that 3/4 of those areas continue to struggle economically, and that 91% of those green-lined areas remain middle to upper income today, and that 85% are still predominantly white. Now, we did away with this practice officially in 1968, and yet we still see the long-lasting impact of this over 50 years later, because houses don't appreciate the same value. So even if a family had been able to purchase their home in a redline community, which was less likely because mortgages were not to be backed in redline communities, if you remember. But even if they had, the cost of their home was not going to appreciate at the same value because that community had not been invested in. And so they weren't able to just immediately say, oh, well, the law has been passed, I can move anywhere I want to, so now I can. And so some people have started saying, that economics is the new way to be able to be racist, because if you have a racist system and then you just do away with the practices but don't do anything to right the harms that happen, you continue to perpetuate the patterns that were established by that practice without having to be as overt about it. And so that's one of the challenges that we're up against, is that we do away with things that were harmful, but we don't also create the reparative notions that are needed to be able to address the harms. And so then we build other systems right on top of them and continue to see the same patterns, and then pretend we're unclear about why that's happening. Second example of this, and we'll circle back to redlining in a moment, but another example of how the personally mediated racism can become institutional racism based on the power that a person holds and how they then codify their beliefs into policy. And so Harry Anslinger was the first commissioner of the Federal Bureau of Narcotics, and he occupied that role. The Federal Bureau of Narcotics is the precursor to the Drug Enforcement Agency, or the DEA today. And he held that role for 32 years. And he existed, historically speaking, in this time where things were changing a lot. The US was having more immigration. We had finished the period of Reconstruction right around the time that he was, sort of being born and coming of age. And so he is in this position where he's watching some of the social norms change. Women get the right to vote in 1920. There are all these things happening that he's uncomfortable with, and he's worried about how that change is going to impact him and his ability to be able to maintain power, especially as a white man in a system that was designed to keep white men in power. And so he had some beliefs about marijuana in particular, that it made people of color think they were as good as white men, and that it allowed these people who he didn't think should be to be able to have sex with white women. And he was very concerned about this. And so he really made marijuana this like boogeyman in his mind, even though on numerous occasions, 1944, the New York Academy of Medicine said, Anslinger, this is not doing, like marijuana doesn't do what you keep saying it's doing. There's no data to suggest any of these things that you're putting out. And he persisted. And so we see the impact of his beliefs and him being the head of this agency is that he was able to get the Boggs Act passed in 1952. And that implemented mandatory sentences of 2 to 10 years for possession. And then the Daniel Act, which allowed for sentence enhancements. So you could get up to 8 times the penalty. So you could get 80 years for simple possession, depending on what the other circumstances of the arrest were. And then as we have observed in many instances, then the states began to enact little Boggs Acts, right? Something happens at the federal level and the states go, yeah, us too. And so they began to do that. And so this is really how so much of our war on drugs got started. I also want to make it a point that the very first drug laws in the United States were actually passed right here in California, and they were also racially motivated. There were Chinese immigrants who were coming to the United States and used opium in part because they were being overworked, and it was a way to be able to alleviate pain and stress and cope with the stresses of the jobs that they were doing. And it was outlawed in the late 1800s specifically to target the Chinese immigrants. And so we have a history, right, of passing drug laws in a way that is targeting people racially because of our presumptions about them that's not rooted in science or any sort of public health or public protection. And so if we fast forward, our organization worked on this report that we put out just over a year and a half ago called When the Smoke Clears, where we're looking at racial disparities in California's marijuana arrests. We fast forward from 1996 to 2016 when the Adult Use of Marijuana Act was passed, known as Proposition 64. And we look to see what the arrest numbers look like in that 20-year period, even during the time where medical marijuana existed and where there seemed to be a move towards decriminalization of marijuana before it officially became the law of the state. And what we found is that across racial and ethnic groups, people were using marijuana at about the same rate. I joke and say, we can almost agree on nothing, but the one thing people seem to agree on is about how many people in every racial and ethnic group are going to use marijuana. And yet, even knowing that our use rates are almost identical, statewide, Black people were 4 times more likely to be arrested than white people for marijuana. And then if we take a look more locally in Sacramento, where I am, Black Sacramento residents were arrested on marijuana-related charges 29 times more often than white residents, which was 7 times the state average. And many of the places that Sacramento was the highest in the state in terms of that disparity, but many of the places in the state that had the highest numbers were right in Northern California, including the Bay Area. San Francisco was up there. There were a lot of places really close by that had very similar practices. And so the impact on the war on drugs, right, was community trauma, right? We incarcerated and separated families, and even people who were not incarcerated, who took plea deals. If those plea deals included a felony conviction, that could jeopardize your immigration status, your child custody, your employment, your housing, and your social services. And thankfully, about 7 years ago, there was a bill that was passed that allowed people who have felony convictions to not be excluded from some of the social services. But there are still a number of jobs and licenses and things like that that you are just simply ineligible for because you have a felony conviction. And so with the passage of Proposition 64, there is an opportunity to expunge records. But what does expunging a record do when someone has experienced 10 years of being underemployed because of a conviction already? How do you make up for that time? How do you make up for those lost wages? And how do you put them on a path where the thing that they did where they crossed over a line of legality no longer is the case? But do you do anything to be able to support people from the community who were impacted by that and their families? And so I brought this example up of the war on drugs because the way that this was able to be done so expertly is because it was layered on top of redlining. At the time where we were telling people where they could live based on their race and ethnicity, and then the person who's over the DEA has very strong beliefs about who's using marijuana, you can focus your law enforcement efforts on the people and the locations where you think marijuana is being used, and seek and you shall find. And so that is exactly what happened. And so it's one of the ways that our institutions combined, right? So we had, this law on the land, we had law enforcement come along to be able to to implement their practice on top of the law of the land, which was where can people live? And that created, a lot of the racist practices that allowed for the disproportionate incarceration of Black and brown people, especially for drug-related offenses. And so part of then what we see, zooming in again on Sacramento, is that the top 5 census tracts in Sacramento where people were booked for marijuana also have median household incomes ranging from $12,000 or so to $36,000, which is less than 60% of the state median income. And I want you to just pay kind of close attention to this map, because you'll see a similar map that's going to come back. And I want you to just note some of the places where you're seeing the dark colors. So the impact of redlining here is that schools, right? If we think about how schools, especially prior to the local control funding formula, were funded, they were funded by the tax base of their communities. And so if you tell people where they can live, and where they can live has economic, consequences in terms of there being more money or less money available, then you have automatically set your schools up to be, disparate, to be separate and unequal, because you're not able to, if you require people to go to school in their neighborhoods, they're not going to be able to have access to the same resources, and they are going to have many more challenges, because we know that concentrating people who are experiencing poverty because of social conditions, not because of any moral or personal failing, then is one of the conditions that leads to increased violence and obviously crimes of both opportunity as well as crimes, of survival. And so if you have an increased police presence there, you're more likely to experience incarceration. So, and then of course, with all of the rules for redlining, one of them was don't place businesses, and that includes grocery stores. So we see many of our food deserts are in some of the same communities that were redlined, and all of these things are layered on top of each other. And so even the community maintenance, the Sacramento Tree Foundation does a lot of really great work showcasing that, the tree canopy was maintained in the more affluent neighborhoods of Land Park and East Sacramento when it wasn't maintained in South Sacramento and some of the other places that were redlined. And so the consequence of this is a lowered life expectancy and lower overall health status. And so this is what we see persisting even today. And so when we go back to look at our COVID numbers, and when we talked about Sacramento suffering inequitably, I showed you the map before of, the top 5 census tracts. You can see that those darkest census tracts also closely overlap with the places that we saw the most, the highest COVID numbers. And that's not surprising, because the material conditions, the underlying risk factors were all there to make this happen. We can recognize that the differences in who was impacted by COVID can be entirely explained by structural racism, right? Because there is this cycle that is driven by social determinants of health that results in an increased risk of infection, an increased risk for complications, and an increased risk for the economic and social consequences that the pandemic brought down on all of us. So I bring all of this up because sometimes when we talk about redlining and the war on drugs, it can feel very historic, right? I mean, we're talking about some of the things, especially the legalization of marijuana that's happened more recently, but generally speaking, it feels like, gosh, that was a long time ago. What are we going to do? Like, why are we talking about this? It's great to know history, but how does all of this kind of play out, and what is the role? Well, I have pulled just for us, some of the headlines over the last year and a half of the ways in which redlining shows up and continues to cause harm. The first one is, I'm not crazy, why California Latinos carry more worries in the pandemic and why many don't get help. COVID shortens US life expectancy, with Black and Latino communities most hurt, study says. Gun assaults increased during the pandemic. See the trend for your Sacramento neighborhood. Sacramento's tree canopy reflects the city's inequities, how a $250 million plan could help. The face of hunger. Thousands can't afford to eat in Sacramento, how COVID made it worse. Updated reports find Sacramento City Unified suspends Black students at, quote, egregious, end quote, rate. And a wound that never closes, racism, police violence, and the toll on Black mental health. And this is just a sampling. I actually excluded numerous headlines that I could have included on this slide just to be able to cover most of the topics that we've talked about. But this is the impact right now of these policies that were passed. And so we are stuck trying to figure out how to protect children and how to protect communities in the aftermath of not doing what was necessary when these policies were repealed, which was figuring out ways to be able to meet people. And it's a problem that we continue to have happen over and over again. So I mention all of this because part of what we're trying to do here really is to move away from, sort of where we often act, right? If we're thinking about prevention, we often think about it as primary, secondary, and tertiary prevention. So primary prevention is when you prevent something from happening in the first place. Secondary prevention is when you prevent it from getting, worse or progressing to your worst outcome. And tertiary prevention is essentially treatment. It's already happened and you're trying to make sure that the consequences of that are lessened. And so secondary and tertiary prevention can sometimes, kind of be a little unclear where one ends and the other begins. But we often think about it as like preventing you from ever getting sick, you being kind of at risk, and we are screening you so we can maybe prevent a diagnosis, get you, take the pre-diabetes and get you back to where you need to be, using that as an example. And treatment being you have diabetes and here's how we treat you to make sure that you don't have complications. And so a lot of our time and attention is spent trying to treat. And certainly that's an important role to play. We will always need treatment. But we also need to spend a lot more of our time and energy on prevention. And especially when we think about children and the opportunity there to be able to right wrongs, we have a moral duty to be able to figure out how to adjust some of these systems so that the impact doesn't continue to persist. Because the greatest travesty in all of this is that we set these conditions decades, generations ago, and that we've done nothing to disrupt these patterns, so that we're just continually traumatizing a next group of children and putting them in conditions that we already know the outcomes of because we've been watching it happen for decades. And so that brings us to sort of what are the implications for practice, right? And the first one is that we have to recognize community trauma and historical trauma that arises from this institutional racism and oppression and discriminatory systems and policies. And we also have to, at the same time, be able to recognize and address individual trauma. So we don't want to end up with, only focusing on one or the other. People are human beings who are experiencing what they are in this given moment, and they're also reflecting patterns that have been set long before they were born. And so we have to have a both and approach to how we are going to address what's happening. And of course, the challenge is always, and I love this little animation because it's like, who wants change? And everybody's hands go up. And then it's like, who wants to change? And everybody's hands go down. And it's like, well, who wants to lead the change? And there's nobody there to be heard because this is hard work and we're exhausted and really trying to figure out how to survive. And so taking on something as big and heady as some of the, the legacy institutions that we're talking about here and really doing something different, not just the incrementalism, but really doing something to shift our practices is hard because it requires us to also shift our mental modes around what's possible, around how things should be. And in some ways, it may even feel like we're losing something because systems that have been set up to be unjust, often the people who are leading them have figured out a way to be able to benefit from them. And so when we start talking about, well, what does it look like to be able to, to change that, we're also talking about, changing power. And so there can be a reluctance, even among people who say that they care about these issues, to actually do something that is going to change for them. So the first thing we need to do is we need to make trauma a priority, right? Because emotional safety needs to be considered similarly to our other basic needs. It's a risk factor for behavioral, physical, and mental health outcomes. And so we really need to consider what has happened to individuals and communities instead of something being wrong with individuals and communities. That's central to the mental model that needs to shift. And unfortunately, so many of the helping professions are designed around what's wrong with people and not what happened to them. And just that shift in our thinking can really be helpful in terms of us thinking about primary prevention. An example of that is what would happen if all the resources that are thrown at foster care were thrown at families before they had a familial separation. How many of our foster care placements could be prevented if people had adequate social support and treatment and childcare and money to be able to live where they are? I think the Stockton Universal Basic Income pilot is a great example of what happens when we stop the paternalism of, hey, people without money don't know how to spend their own money, and we give them money and see what happens, because often they may not make the choices that middle class people would make with the money because they don't have middle class means, but they do things that are actually able to help and support their families in ways that are helpful to them and also increase their own agency. And that can be incredibly important. The other thing is that our place in the layers matters. And so similar to Harry Anslinger, who probably saw himself as an individual and was just doing his good duty, he was, though, an institution. And I'm sure, as one of the first people in that institution, and as the head of it, he had an outsized impact on the institution. And just like we said before, that systems are designed and maintained or disrupted by people, and that every level of dehumanization sustains dehumanizing systems that have been put in place and contribute to institutional dehumanization, the same is true for liberation and healing. And so part of what we need to identify is that when we are operating on behalf of an institution, we certainly are individuals, but we are that institution. I use the example of when people say, I don't like X, Y, and Z health plan, or I don't like X, Y, and Z health system. They are not talking about the entirety of the, hundreds of thousands of people who work for that health system. They're talking about their doctor, and they're talking about maybe 3 people at most, right? Like their healthcare professional, the person who answered the phone, and the person who greeted them when they walked through the door. They don't interface with hundreds of thousands of people. So you are the institution when you're working on behalf of the institution. And so that's an incredibly important thing for us to recognize, is that we are the institution. And so we see ourselves as individuals, but we have a much bigger impact that we are having. And that comes with a much bigger responsibility as well. And so there are 3 challenges that I want to leave you with. The first is challenge yourself, right? Learn the story. So often we helicopter into communities, and that maybe you're from a place, but you're not from the place that the people you're serving and partnering with are. And so you don't know the history, but every community has a history and is writing a story. And so your interaction with people continues a conversation that predates you. And so knowing what's happened in the community can help you to recognize and preempt access barriers and concerns and fears and mistrust and questions and misconceptions and structural issues. It's a way to learn compassion and not stereotyping. And so it's incredibly important to move into a community and really take time to get to know the community, to get to know what has happened, to get to know how people are thinking and what they're experiencing now, but also what's happened over the course of a community. I'm from Pittsburgh, Pennsylvania, and I'm telling you, if you come to Pittsburgh today, even though there's not a steel mill in sight, you don't understand that this is a steel town, you will be missing the forest for the trees, because Pittsburgh, within the context of Pennsylvania, is this steel town, and it still is all these years later. And there's a way that continues to impact the culture there, and you have to understand that in order to be able to make meaning of what you're seeing. The next challenge is to challenge your work. So we really need to develop solutions, because good practices and policies must be institutionalized and sustainable. We cannot rely on charismatic leaders and organizations to be able to do the work, because just like Harry Anslinger did a lot of damage, somebody great can do a lot of good. But then when they're gone, the question is, are those good things able to be maintained as easily as some of the bad ones are? And the key to that is institutionalization. So if Harry Anslinger just had a bad attitude about, Black and Latino people in marijuana, and he was there and he did no policy work, that just would have been his tenure, and then it might have been over. But because his tenure also allowed him to pass policy that reflected those beliefs, that lived on without him. And so the same thing needs to be true for passing good policies and practices that are healing and restorative, is that they can't just be the practice while you're there, that you're creating this work environment that sees people and that does the good work in the community, and then you're gone and everything goes back to normal. We also need to think about addressing root causes. We can't just think about the here and now. We also have to think about what is needed in a community that is going to promote healing and prevent new harms and repair past harms, because we have tried our very best to forget the past and just move on from here out. And I want to ask everybody who says, well, that was a long time ago, we shouldn't be talking about it, we're just going to taint a new generation. And I want to say to them, how's that working out for you? Really? How is that working out for us to pretend these things haven't happened? How is it working out for us to pretend that we're protecting people instead of equipping them with the tools to be able to do something different? What is our responsibility to be able to actually think about promoting healing and preventing new harms and repairing past harms? And I think that responsibility is high, especially if we are in institutions. And lastly, what would it look like for us to do this for some of the things, like as an example, for marijuana or housing or some of the other things that we know are impacting entire swaths of our community, that are impacting parents and children, that are making our lives really difficult? What would it look like if we actually try to institutionalize some good practices and make them sustainable? And then lastly, I say challenge your life and keep it going. So we should constantly be in this continuous quality improvement for the work that we do, of thinking about what are we currently doing that is certainly working and that we want to continue doing because it works well. What are we doing? What aren't we doing that we need to start because there's enough data and enough political momentum or enough, people within our institution that we could make that happen, even if it's on a pilot basis. And what are we going to stop doing? Because we know it isn't working. We know it's harmful. We know it's not fitting into the model of wanting to repair past harms and wanting to prevent future harms. We know it's not what we're doing is not, sustainable or is falling into the category of stereotyping or is creating harm in a community. We're simply not working. How do we make sure that on a day-to-day basis, we are looking back and we are constantly trying to learn and grow and do things in a way that not just externally make things better, but also internally, because the first influence you have as a system is on your employees and the people who work within it. And so I frequently say to my staff and my colleagues on executive team, if we can't get this right for the 44 people who work for public health advocates, we're not going to get it right for the 40 million people who live in California. So we have to start with ourselves. We are our first pilot. We have a duty to ourselves, and we need to really secure our mask before assisting others. And so that's my last challenge to us, is to keep this going. And of course, I would be remiss if I didn't say, for all of the great work that you're doing, that you're going to continue to do, may the force be with you.
Thank you, Dr. Kofer. You were getting many claps in the chat, and I think it was someone wrote me and said, this is just what I needed today. Thank you. I do have one question. Dr. Mendoza, I think we only have time for one. Dr. Mendoza from Stanford asked, how can we show that increased risk by social determinants in poor communities are a risk to the rest of the community, particularly when, I will say, 3/4 of our children in this county are children of color, and these are our future citizens?
Absolutely. I was hoping that, so going into this pandemic, I'm a silver linings person, right? So I'm like, let's prevent all the things that we can, and then let's try to figure out what are the things that we're going to learn from this that will, be terrible, but will also allow things to be better in the future. And my hope was that it was going to be really clear to us as we're talking about, a respiratory illness that is infectious in nature, that there certainly is an impact that we're going to have there, because we are going to interface with one another. And so this disease is going to spread. And unfortunately, that didn't happen. But what I do think could happen is if we start to shift some of the mental modes around poverty, right? So one of the dominant ones is that poverty is a moral failing, that if you just worked harder and pulled yourself up by your bootstraps, you would not be in poverty, and not recognizing the systems that are put in place to keep people who are experiencing poverty in poverty, right? And so it's incredibly important for us to draw those lines for people. And I think sometimes we take for granted that everybody is kind of on the same page and recognizing, because we're seeing these data all the time. And for those especially who have been doing this work for a long time, you're familiar with so much of what's happening. And we forget that that's not how most people are seeing the world. And many people are still seeing it as, if you're poor, you needed to do better and you need to make different decisions so you could stop being poor. You need to stop buying sneakers, and, or the generational one that always amuses me is, if you millennials would stop buying avocado toast, you could have a house. And I'm like, yeah, $6 is the difference between having a down payment to be able to buy a home or not, right? But there are these ways that become part of the dominant conversation. And so I think part of what we need to do is really begin to dismantle this idea of poverty, because it is creating a situation where it's us versus them, right? Where people are not recognizing that folks who are unhoused were often just one bad event away from being you. Like, most of us are in class solidarity. I jokingly say sometimes that my poverty looks a lot nicer than other people's, but I have no misgivings whatsoever that I am in class solidarity with people in poverty, because it means that my material conditions are certainly met, but I'm also incredibly aware that I have done nothing to be able to enjoy the privileges that I do. and also that they could go away. I am one illness, one extreme expense, one whatever away from not being in the same situation. And I think that's true for a lot of folks, but we don't admit that out loud. And we don't behave and legislate and come up with policies that reflect that reality. And so I think that's part of what needs to happen, is that it's not just, half or three quarters. It's most people are in this position, right? We have the most extreme wealth inequality on the planet, in the United States. And so, we need to be really clear about what that means for so many people, and not to see ourselves as being that different than sometimes the people that we're serving. And I think that's one of the ways, is shifting those mental models. I think another piece of this that could be really helpful is also us better recognizing what those social determinants of health are and being able to point them out. So it's a really wonky word, and I'd love for a really wonky term, and I'd love for some of our communications specialists to be able to come up with something similar to, what the California Endowment came out with in terms of life expectancy, to be able to help us talk about this with folks, because it's important for people to really understand and to be able to see. And I think their lived experience jives with it, but we haven't found a way to mainstream some of these things. They're still very much in academic and professional circles, and we need people to be talking about these material conditions in very similar ways.
Talking to mute. Thank you, Dr. Kofer. We really appreciate your presentation. And I talked to Vice President Ellenberg yesterday about institutionalizing some of the great things we're doing. So I really appreciate your time, and I'm sure there's going to be many people reaching out to you afterwards. So thank you so much.
Thank you.
And may the force be with you.
May the force be with you all.
Next, we have Dr. Marianne Duwan. Many of us know her, and about maybe 100 people on this virtual Zoom consider her best friend. And so has over 33 years in education. She's won many awards. The latest one was Superintendent of the Year Award, which I think is pretty special. And she earned her doctoral in educational leadership from Indiana State University. And she is going to introduce her panel. Thanks, Dr. Duwan.
Thank you, Kathleen, for having me today. And just a special thanks to Dr. Kofer for her inspiring words and for leaving us with the notion to reconsider how we think about and talk about poverty and its impacts. It is my pleasure to introduce the next session of today's agenda, which will feature Jim Morgan and Irene Chavez. First, Jim Morgan, an influential nonprofit and philanthropic leader based here in Silicon Valley. He has worked extensively in the worlds of both for-profit and nonprofit organizations. He led the semiconductor equipment giant Applied Materials for nearly 3 decades, one of the longest tenures of any Fortune 500 CEO. In 2007, Jim co-founded with his wife, Becky Morgan, a former California state senator, the Northern Sierra Partnership, a pioneering collaboration bringing 5 conservation nonprofits together to do what none could do alone. The partnership has successfully preserved over 103,000 acres in the California Sierra Nevada mountains. In 1993, Jim and Becky co-founded the Morgan Family Foundation, and their shared goal is to change lives and transform communities. Jim says of his work with applied wisdom for the nonprofit sector, I hope to provide succinct leadership tools and techniques for people who work in nonprofit organizations, small or large, new or well-established, regardless of their position or title. And I personally want to say thank you to the Morgan Family Foundation for supporting our Steps to Success initiative, which is helping us transform the system of communication about early care and education for families. Jim served as a technology advisor to 3 U.S. presidents, including George H.W. Bush and George W. Bush. And in 1996, he was presented with the National Medal of Technology and Innovation by President Bill Clinton. Irene Chavez is the Senior Vice President and Area Manager of San Jose Santa Cruz Kaiser Health Plan, where she leads the hospital operations, health plan operations, and community benefits, covering over 260,000 members from San Jose, Gilroy, and Santa Cruz County. She's worked for several health systems, including Tenet Healthcare, Providence Memorial, and a physician joint ventured health system, El Paso Specialty Hospital. She was president of a health plan specializing in self-funded employer and carrier structured entities. Welcome to both Jim and Irene. We're going to go next to hear a little bit about a conversation that Jim and Irene had on applied wisdom for nonprofits. Please join me in watching this video.
Hi, my name is Irene Chavez, Senior Vice President and Area Manager with Kaiser Permanente, and I'm here with
Jim Morgan.
And we are going to be talking about principles related to his wonderful book called Applied Wisdom. And what a wonderful, wonderful title, because it is jam-packed with wisdom. Oh, good. So my first question is, how did you empower your employees to contribute to the organization with the use of questions?
Well, one of the things I found that helps is you need to think about culture, planning, and implementation. And that's what the Applied Wisdom for Nonprofits is, the sections are. And to have the right people to be able to make decisions and go forward, it helps to have a accepting culture. So I know we used to say good news is no news is bad news, and bad news is good news if you do something about it. So there was a pretty free flow of information from all levels of the company. And that was important also because there were so many cultures. In fact, back in the 80s, there was a couple of them that were executives during those times, and I saw them a couple months ago, I guess now. And they said, what was the same? They'd had lunch, and so they asked each other, what made them alike? And turns out what it was is they were all 8 of them a different culture, even back in 1980. And so that was sort of the environment that we built over the years.
So as a result of that diversity, you invested in your staff quite a bit. Right. Tell us a little bit about why it's important for boards to have diversity.
Right. Well, I think for the same reason, because you get a diversity of thought. And the world is, at least over the last years I've been an executive, and looks like it'll continue to be, there's just, things are changing all the time. And so, and it's global, and it's multicultural, and if these groups, if they don't have a vision together and what you might call a purpose, then it's really hard to make decisions. And so culture then becomes really an important piece of it, and then the planning, and then of course, implementation is still 90%.
Yes, I love that quote. 10% planning and strategy and 90% implementation or execution. Throughout your book, it is evident that you were a fan of creativity. Right. So share with us a little bit about how you encourage your employees back then and how you encourage donors in nonprofit organizations to be creative.
Well, I think one of the things you have to think about is what is the reason why your organization should exist. And that gives a purpose and a vision and can set a framework. And then if you trust the people, then the decisions can flow and people can be accountable for their what they did or what they decide, and it isn't kind of manager's fault or somebody else's fault. It's they accept that they made the decision. They accept to clean it up if it's a problem.
Yeah, you definitely spoke about accountability and how important that is. And as much as one would dream and think that Jim Morgan is the easiest person on earth to work for and with, how did you handle when you had to disagree in an amicable fashion?
Well, I generally tried to find out what the other person, or even if we're negotiating with partners, or where they were coming from, what was important to them, or what was their problem, and then try to blend what I thought ought to be right and what they're doing a bit, and that seemed to work. But we did make the tough decisions.
Yeah. So having a common purpose and a sense of importance in the work that's being done is definitely something that you've underscored throughout the principles. How do you feel about the optimism for nonprofits in this day and age?
Well, I think, it's even more clear than it's been, to me, is the role of nonprofits, because it's clearly the government is not addressing many of the problems that we have effectively, and one of the reasons for that, there's too many problems, and you get into too many layers of decision making within those government structures, and so the nonprofits where people are smaller and focused can make decisions. They can they can find new sponsors, and you can just get a lot done that way. And also particularly new ideas, like for example in our what we call investing forward in nonprofit work is that we look for a good reason, and we look for a good leader, and then we try to support them. Not just in terms of the specific tasks that we have in mind, but giving them, being confident that they can improve their organization. In fact, we expect them to improve their management and their operational excellence.
Definitely something that you talk about in the book is developing that trust, because with trust comes creativity and a safety mechanism of working in a place that has similar beliefs in what is meaningful work. Very nice. Great common purpose.
Well, it's actually still lasting, so I guess it got started.
I think so too, Jim.
Actually, there's the sayings from the book, or in the booklet, came from a list of 100 tips that I collected since I was in the Army in 1958.
Wow.
And I just found them really very useful.
They are. They really are. I use them as quotes under my signature.
I saw that. So other people do that too. That's a good idea.
I never dreamed that I would actually meet you, though, so you have no idea how tickled I am about that.
Oh, good. Well, I'm glad it's helpful.
Thank you.
That's our main purpose.
Yes, sir. Well accomplished. It's been a pleasure speaking with you and learning from you. Your applied wisdom is something that I think every first line supervisor, every manager, every director, every CEO could benefit from. These are the things that we eventually come to know. Right. But when you read it again, you think, oh my God, this anchors it so beautifully. Good. And I love your recommendation that everyone should keep a notebook or some sort of electronic tracking of important sayings, Morganisms, or
their own name.
Their own name, that's right. And that helps them propel towards their future with a clear path to how do I contribute? What is my common purpose with my organization? Right. Thank you so much. It's been a pleasure.
We're so fortunate to have both Irene and Jim with us live in person over Zoom today for us to continue this conversation. And I just want to highlight that in the video, Jim mentioned that he had over 100 of these isms, these leadership quotes or ideas, concepts to help guide both for-profit and nonprofit organizations. I also had the pleasure of reading the book and thinking about some that apply to the work that we all do together here in Santa Clara County. And one that really stood out to me that I wanted to lift up today, Jim, is the whole job. Commit to doing the whole job. Investing in organizational capacity contributes to excellence and impact. I want to thank you for including that one in the booklet.
Can you hear me all right?
Yes, we can.
So that idea came from a guy named George Farnsworth, who was on our board. And he was concerned that we weren't thinking about all the aspects of what each organization was doing to reach excellence. And so it became kind of a saying within the company. And it kind of gives you an indication of what a board member can do to influence their organization and why board members are so important. But that was we kind of got a reputation over time of leave nothing to chance, which means you do the dailies, get the dailies right every day at each level and each sub-organization. And so there isn't a lot of time wasted on cleanup. In other words, if the numbers are right consistently, you don't spend a lot of time trying to argue about who's right and wrong. If the technology issues that when you have failures get fixed right away, it's just getting the job done and doing it in every piece of your organization and as best as you can, and over time that becomes a culture.
Yeah, thank you for sharing some of the origin story of that particular leadership ism. And it connects for me and to what we were hearing earlier about how we might need to institutionalize good policies or good changes in practice, and that doing the dailies or the daily disciplines of leadership can really take us to that place where we're able to institutionalize these policy changes and make the work a part of how all of our systems and agencies work. Irene, I was wondering if you had a favorite ism or any isms of your own.
Good morning.
There are quite a few of them, but probably the one we ended up putting as the title of the book that bad news is good news was so important because it enables you to deal with problems when they come up rather than have them hidden. And I found that in retrospect that was so important because Dr. Maiden, the kind of the technical partner over 20, 30 years, was we were having lunch and we neither of us could remember a time in the history we worked together that both he and I didn't know about a serious problem before it got to the board, or before it got to the San Jose Mercury, or before it got to Wall Street. And so that kind of gave you a feedback as to how important that was. So I think as you wander around Silicon Valley, if people have been associated some way with Applied, they'll try to say this: good news is no news, no news is bad news, bad news is good news if you do something about it. Now, lots of times they'll screw up the exact phraseology and get it backwards, but they all laugh and know what it meant.
How about for you, Irene?
Thank you, Dr. Dewan, and good morning. Definitely have some of my own sayings. I'll share 3 of them with you. The first is that there is no such thing as failing, that there is only learning. Because when you debrief from whatever occurred, there are pearls of wisdom that arise. The second is that if you establish that once you're in a comfort zone, you really have to create some constructive chaos in order to stimulate innovation and upward thinking and aspirations. And then the last is my favorite, and that is that the value of the question is more important than the answer. So at every meeting, I'll ask my staff, let's have some provocative questions and learn from them, because they're just rich in opportunity for discussion. Thank you for asking.
Absolutely. I'm going to share a few other thoughts, and at this time also invite any of our participants today, if they have a favorite ism, maybe it's a Morganism, maybe it is one of their own, to please drop those in the chat, and we'll take some time to reflect on some of those. I wanted to mention a couple sayings I think that can help all of us as we continue to address together some of the complex problems that you mentioned, Jim, in the video, the complex problems that are facing our community or our children or our families. One that always stands out for me is do the right thing. And really trying to keep that mantra, that ism, in the forefront, as we're trying to tackle complex problems. And I think Barack Obama's quote from a number of years ago also really resonates with me, and I think has kept us all going during the pandemic. And that was, change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. So, the only thing we can do is what we can do now in the present with this vision towards the future. And, we're the ones who are here all together right now. So doing this work together and doing the right thing. And I have to say this one, not only because I'm here with all of you, but because of the great work that the Healthier Kids Foundation does, and that many people hear me say, you really cannot separate health from education or education from health. That all the metrics that we use to determine, really how a young person is doing are connected into how they're performing in school, or the metrics we measure in school. And when we're concerned about how children are doing in school, we look at things related to their physical health, their mental health and wellness, their behavioral health, and the like. So those are just 3 of mine for today. And Jim, I wanted to come back to you for just a moment. You included a lot of really practical leadership tools and tricks in the booklet, and gave some case studies too. And sometimes it can be hard when agencies or leaders are tackling a lot of complex problems, may not be sure where to start. How would you suggest that a nonprofit leader get started with using applied wisdom?
Well, I think if you use applied wisdom, it's good to just pick 2 or 3 or maybe 5 ideas, and they can be from the booklet or your own, and think about the things that would help you and your organization to move forward the way you want it to. And and then after you get some progress there, because I think momentum is an important thing to have in an organization. We really focused on making decisions. One of the challenges, I think, for all organizations, but particularly nonprofits, there's a little concern about being wrong. And so as a result, you got to keep looking for more information. And in the meantime, the decision may be made for you, because it's not so much the decision you make, it's how you manage the consequences. And I remember in business school at Cornell, I had a professor. In fact, he just died about 3 weeks ago. And he had this chart. It was statistics, and it was the cost of perfect information. And that's asymptotic as the time goes to make a decision. So what I eventually evolved out of that was this quote that is make a decision, manage the consequences, and have just a few things that you're trying to fix at one time. You have maybe many things that are a challenge, but it's kind of, I always had a 3 priority system in my mind for both short term and long term. And the short term I'd keep working on first, but I'd always keep the top 3 long term kind of in parallel. And of course, I reviewed the whole list, but to keep things going. But it's just important to get on with it. Momentum. It's easier to move something a little bit if it's moving, and try to get it started from a dead stop.
Yeah, well said. Thank you. Irene, any other reflections that you really wanted to lift up for our attendees today?
Yes, I think it's important to always have a plan of action and to have contingencies planned should one aspect of the plan not work well. And in total alignment with Jim's recommendation and advice, instead of paralysis by analysis, is that at some point you have to do something, and you take the action, you assess the action. If it is successful in getting the results you're looking for, great, you can establish it as the path forward. If it doesn't and you fail quickly, then you can make the changes quickly and move on and learn from them. It's an iterative process.
Yeah, I'd kind of echo that, because my grandkids, 3 of them call me Opa and 2 of them call me Grandpa, but they all say, well, I have a workaround plan. This didn't work, but I have a workaround plan. So even they picked that up.
I love it.
That's terrific. And thank you for bringing the voice of children into our space today. Want to encourage, again, all of our attendees, our participants today, to share their wisdom. Collectively, the 150 so people here in this space have a lot of shared wisdom and experience. And Jim, thank you for sparking that in all of us and for your contributions and to help us with leadership development. And I want to leave this part of our agenda with a quote that I hope all of you will take into our ongoing work together. And that is, invest more in the systems that we actually want our children to be in. Let's invest more in the systems and the places where we actually want our children to be. So thank you again, Jim and Irene, for your leadership in the conversation today. And back to you, Kathleen.
Thank you, all three of you. I really appreciate it. And Dr. Kofer beforehand and Vice President Ellenberg. We're going to take a break now. This is the time where you do a little mindfulness and a potty break. My special needs son has gotten the part of exhale right. We're working on inhale as part of that too. So go ahead, do some inhaling, exhaling, potty break, and we'll start again at 11:10. And please be sure to come back. We have quite a bit more that we'd like to cover. Dr. Myers is going to talk about the shrinking population of children, which I think is of interest of all of us. So appreciate it. Take your break. Come back at 11:10, please. Thank you all. Hello, I hope everyone had time for a little break, a little breathing. And if you didn't get at the beginning, our chair has recommended every meeting we talk about what we have gratitude for. So if you'd like to put it in the chat, we would really appreciate it. We are now bringing everyone back together. I'm Kathleen King, Healthier Kids Foundation. And we have a link in the chat to our data book. And some of you who signed up early received it in the mail. Others will have gotten a link to it. The nice thing about the soft copy is that it has all the links to each page where the data came from, so you can look further and receive a little more research on it. We wouldn't have been able to complete this book without the help of our wonderful staff. Rena spent hours and hours on this, and I'd like to thank kidsdata.org, www.kidsdata.org. They were absolutely amazing in supplying data we couldn't find. So our chair, Mary Maven, will cover pages 3 and 4. Nadia Ahmad will be covering page 5. Rampy will be covering page 6 and 7. Dr. George Barkuth will be covering pages 20 and 27. And Dr. Carmen Garcia will be covering pages 21 through 26. Laura will be showing the data pages as our board members go through them so that you can just follow along on the virtual Zoom. So with that, I'm going to let Mary Mabin cover the first pages of 3 or 4. Mary, thank you. And your mute is on and your screen is off if you'd like to turn both off. Mary, I don't know. There you go.
Hello, am I
There.
there?
Yeah, you're
Okay. Good morning. My name is Mary Mabin, and I'm honored to chair the Healthier Kids Foundation. My page is on child and youth population, and the bottom line is that our child and youth population is declining in every city across the county and in California. You can see significant losses in the city of East Palo Alto and East San Jose. And the conclusion there would be the cost of living in Silicon Valley is too high, so families are migrating out of here. Another fact is that the children in Santa Clara County schools has dropped 11.7%. And if schools are the cornerstones of the community, I challenge you to ask yourself a provocative question, as Irene would say. What is the impact on those communities when the schools are closed down? On the bottom of the page, it says children are our future. And this isn't just an aspirational statement because children are delightful and they represent vitality and hope. But we need children to replenish our workforce, children to continue the social contract of paying into Social Security and Medicare. If I can change to the next page now, you'll see that California and the US are experiencing declining populations of youth. There's an outstanding statement here that says population growth has slowed a massive 74% year after year from 2019. In other words, deaths are happening and births are not replacing them. So if you look at the chart, the map here, it shows in the red area, this is where the population is declining. If you look at the blue area, this is where the population is increasing. So I end my presentation with an editorially comment. This is an argument, my friends, to increase immigration. Thank you.
Thank you very much, Mary Mabin. Next, we will go to Nadia Ahmad.
Good morning, everyone. Name is Nadia Ahmad. I'm with KPMG and I am on the board as well. So speaking to go into this a little bit further as to the declining population, we're definitely looking at a declining birth rate. And at first we might think, why does this matter? We're limited on resources already. So wouldn't it make sense to have a smaller birth rate percentage? And that's not the case at all. What we're looking at, as Mary commented on, is a lower birth rate ultimately means that we are going to have a smaller population in our workforce. It means that we're going to have less putting into taxes, funds, and to be able to support the resources that we have, and to be able to grow our economy starts to limit. We are not the only county experiencing that, and we are not the only country experiencing that. This is being experienced around the world to the point that 30% of the countries now around the world are looking at ways to incentivize families to have more children or to have children at all. And some of that comes from all of the things that we've previously talked about, and making sure that we have the resources in place to be able to help people want to have children, enable them to have children, because they know that they're going to have the resource support in order not only to have children, but to allow those children to thrive in society. Some of the reasons of the decline, one is obviously cost of living. I remember when my husband and I were first having our child, I said to him, I don't want to raise a child in an apartment. There's this American desire to have a family with a yard and a home and walk to school. And so that image is something that pushes into decision making. Also, the cost, and that is the income that is taken away when a woman stays home to have a child, and that income reduction, especially in communities like the Bay Area, really make it difficult for what is already a two-person working family to be able to reduce down to one. What we are also additionally seeing is that some of the birth rate is a healthy decline, which is the decline of the teenage population, because we do want those people to be able to achieve their full education, to be able to take part in the workplace, and to be able to be skilled so that when they go home and stay home to have a child, that they're able to come back into the workforce and are not kept out of it because of having a child at the teenage years. So there's many factors at play here. And part of everything that we're doing, not only as an organization, but as a community, needs to make sure that it is not only helping our current population, but is helping to allow a future population to thrive. And with that, I'll turn it over to our next board member.
The next board member is Angel Rampy, and she will be speaking to pages 6 and 7.
Thank you very much, Kathleen. I'm going to be focusing on children living in poverty. And there's actually some good news and some challenging news there. If you look at the bar chart, the blue and red bar chart, it shows in 2019 the poverty rate in California. And the blue chart shows us that in 2020, the poverty rate actually went down, which you would say, wow, this is great news. But look at the little information in the bottom of those bar charts, because it shows you that the state's poverty rate nonetheless remains higher than the nationwide rate. So California has long been a high poverty state. And you might say, why? Well, most of it is really outweighed by our very high housing costs. Now, there was the federal credit tax that was started in May of last year, and that really helped with the poverty issue. And if you notice in the chart there on the right-hand side in the bottom, the poverty rate went down, but it's ended in December of last year, it ended. And so if you notice, the poverty rate has gone up again. Now let's go to maybe some amount of good news, and I'll turn to the next page. So what has happened since then? Well, in 2021 to 2022, California state budget established California Historic Universal School Meals Program. This actually reimbursed qualified public and charter schools for breakfast and lunch served, if not covered, by the federal programs. It also helped to reduce stigma. It didn't sort of separate the children who needed this and the children who didn't feel or the children were not qualified for this program. Now all the kids are actually given these meals, because beginning in 2022 school year, proudly enough, California became the first state to implement a statewide universal meals program for all children. And this program is actually designed to build on the foundations of the federal national school lunch program and the school breakfast program. Now, what is interesting is that my daughter-in-law actually is a part of a charter school, and I chatted with her yesterday. And she said this program has been really beneficial for the school. The charter school is an all Black school, and she said it has really helped out as well. But she said they're not only getting their breakfast and their lunch, they're actually also getting snacks. And the principal actually set up a plan to get these children to really get their lunch, to get their meals. And so they have to clock in. And when they clock in, they're given their meals. So to reassure them that they are, in fact, getting their meals. So I'd like now to end here and turn it over to Dr. George Bargo. Thank you.
Good morning, everyone. My name is George Berguth. I'm a general dentist and dental director at Garner Health Services. Working with Healthier Kids Foundation gave me a great opportunity to work closely with the children in our community. Page 20. There are some recommendations that we would like everybody to be aware of. But before we start with the recommendation, I would like everybody to know that tooth decay is most common chronic infectious disease of childhood and develops when a child's mouth is infected by acid-producing bacteria that is passed from parents to child through saliva. According to the American Academy of the Pediatric Dentistry, pregnant women and children should follow the recommendation as an oral health guideline. For prenatal, have an oral evaluation, be counseled on a proper oral hygiene, and be referred to preventive and therapeutic oral health care. Using xylitol gum at least 2 to 3 times a day, evidence significantly decrease further child's caries rate. For newborn recommendation, as soon as the first tooth erupts, brush twice daily with a small, soft brush. For children at moderate to high risk caries, use a smear of fluoridated toothpaste. Begin flossing when adjacent tooth surfaces cannot be cleaned with a toothbrush. Children's first dental visit should be within the 6 months of eruption of the first tooth and no later than 12 months of age. Recommendation for professional application of topical fluoride. For children at moderate caries risk, it should be applied every 6 months, and for children with a high risk, every 3 to 6 months. Primary and permanent teeth, we're going to be applying some sealants on pits and fissures. For caries susceptible primary and permanent teeth, and it should be placed as soon as possible after eruption. The toothbrushes should be replaced every 3 months. Please, page 27. Okay, 8 years. In the last 8 years, 104,000 dental screenings were done. 32 referred to urgent or emergency dental care. So basically 1 out of 5 received dental care. Healthier Kids Foundation estimated that 2,000 children in Santa Clara County go to school with pain, infection, or severe cavities each day. During 2021-22 school year, the referral rate being increased to 41%. We could see that over the last few years, that referral to a dentist was decreasing over time, except last year that it's been increased to 41%. I would like to talk about Pregnant First program. The purpose is to educate pregnant patients and their partners about the importance of oral hygiene through a free 30 minutes in classroom interactive and informative presentation and connect them to a dental care through tailored individualized care coordination to improve caries. From the screening results, we could see the reduction of the dental referral to dentist and treatment, as I said, but the last year it's been increased. Dental screening is not mandatory requirement for children in school versus vision and hearing that it's mandatory requirement. Thank you.
Thank you, George. Our next presenter is Dr. Carmen Garcia on pages 21 through 26.
Good morning, everyone. Carmen Garcia, Superintendent of Morgan Hill Unified School District. I'd like to provide a summary of pages 21 through 26 and end with a couple of examples of how these data affect our school district. On page 21, specifically, prior to the pandemic, we saw an increased need for mental health services in schools, but the pandemic has exponentially impacted this need across California, with 66% of students saying the pandemic has impacted their mental health. At the same time, California is experiencing a shortage of mental health providers across the state. On page 22, to further highlight this mental health crisis, a statewide survey of over 1,200 students from 45 school districts in over 20 counties showed the pre-pandemic 69% of students rated their mental health as a 7 or above on a scale of 1 to 10, where 1 is terrible and 10, you're doing really well. But a follow-up survey showed a decrease of 43%, with only 39% of students rating their mental health as a 7 or above. On page 23, in response to this growing need, the Santa Clara County Office of Education opened 11 wellness centers throughout various school districts, where approximately 3,500 students have visited seeking help. After their visit, 82% of the students reported feeling calm and found their visit helpful, with 84% indicating they would visit again. On page 24, the pandemic has also had an impact on youth suicides. We see a spike in youth suicides ages 5 through 19 years old around 2020, which is suspected to be connected to both the effects of the pandemic as well as the impact that social media has on students, including bullying, peer pressure, and shaming. On page 25, there has also been a spike in deaths due to drug overdose during the pandemic. From May 2020 through April 2021, more than 100,000 people of all ages died from drug overdoses in the United States. According to the CDC, approximately a 30% rise from a year earlier and a near doubling over the past 5 years. Furthermore, drug deaths among children ages 10 through 14 more than tripled from 2019 to 2020. On page 26, this school year, Healthier Kids Foundation expanded the emotional wellness checks that were piloted the year before. This additional screening is intended to complement the existing physical health screening programs, moving toward a whole child approach. In total, 2,514 wellness checks were completed, 500 parents participated in parent support calls, 78 referrals were made to behavioral health, and 168 referrals were made to basic needs services. In Morgan Hill Unified School District, we too opened wellness centers, 4 wellness centers at our 2 middle schools and 2 high schools, in addition to wellness rooms in our remaining K-8s and elementary schools. These wellness centers are open to all students and staff in the district. And to date, over 11,000 student interactions have taken place in these wellness centers and the wellness rooms that are not part of the class time. We've also had 5,738 one-on-one check-ins with counselors. And the top reasons are as follows. For elementary, it's a counseling that's one-on-one or group counseling. At the middle school, what the students are telling us is, I am feeling anxious, or I need to calm down and de-stress. And at the high school, I'm feeling anxious, I'm feeling depressed. And more specifically to the 5th grade screening, 88% of our 5th graders were screened. 4.4% of those students scored 3 stars, which indicate lots of risk factors. 29% of those screened scored 2 stars, some risk factors, and 66.4% scored 1 star, low or very few factors. I bring the school district perspective because we did receive one-time dollars to help meet this overwhelming mental health need. As a superintendent, I like to advocate that we absolutely need to double down on investing in ongoing funds so that we can continue to support our students. Thank you so much.
Thank you, Dr. Garcia. That was brought it right down to the school level. I appreciate it. Next, we have Rishna, who's a fifth grader, to introduce the next speakers and presentation on universal mental health. Thank you, Krishna.
Hello, my name is Sri Krishna and I'm in fifth grade. I'm excited to introduce the My Health First presentation that will feature Dr. Anu Gurukanti, who will be supported by Dr. Anya Artigas, Brenda Salcido, Claudia Colindres, and Laura Clendaniel. Dr. Anu Gurukanti is a pediatric hospitalist at the Santa Clara Valley Medical Center and board member of the Healthier Kids Foundation. She is particularly interested in the care of immigrant and refugee children, improving access to pediatric mental health care, and is committed to addressing racism as a key driver of inequities in our healthcare delivery systems. Dr. Anya Artigas is an educator who serves as the coordinator of mental wellness support services at the Alum Rock Union School District. She has an extensive background in trauma-informed school counseling, program, and partnership development, as well as mentoring and development of emerging counselors. Dr. Artigas has devoted her time in education to supporting students and families in navigating systems to access services and resources that address mental health and other basic needs. Brenda Salcido is the administrator of wellness programs for Franklin McKinley School District. As a passionate licensed clinical social worker, she's committed to helping children thrive through reducing inequity, strengthening resiliency, and building the capacity of families, communities, and schools using a social justice framework. With nearly 10 years experience working in schools, she's accomplished in organizing school work teams to improve the overall wellness of the larger school community. Claudia Colindres is a parent advocate with Healthier Kids Foundation. In her role, she develops close relationships with families throughout Santa Clara County and assists them in accessing supportive services. Laura Clendaniel is the Vice President of Operations with Healthier Kids Foundation and supports the agency in developing and expanding programs in Santa Clara County. Thank you.
Hi, everybody. Krishna, thank you so much for that wonderful introduction. My name is Anu Gorokanti, and I'm a pediatrician at Santa Clara Valley and have the privilege of being on the board of the Healthier Kids Foundation and have been an active participant in the My Health First program. So I just want to thank everyone so much for coming to this annual symposium on the status of children's health. We've had such an incredible group of panelists and attendees who are all doing really amazing work in our communities, and I feel so grateful to be spending the morning with all of you. So before we begin, I want to encourage people to ask questions throughout the presentation using the Q&A feature, and we will go over some of your important questions at the end of the presentation. So to begin, I'd love to give a brief introduction to the Healthier Kids Foundation. So just to summarize for all of us, the Healthier Kids Foundation is a nonprofit which was established in 2000, whose vision is for all Silicon Valley youth to achieve good health, educational equity, and success in life as productive community members. Their mission is to remove health barriers impacting the learning and life success of Silicon Valley youth. And to date, Healthier Kids Foundation has provided 450,000 services to youth and families in the Silicon Valley over the last 9 years. So if you're familiar with the Healthier Kids Foundation, you likely know us for our physical health screenings for vision, dental, and hearing. So today we're here to talk about the My Health First program. And the Healthier Kids Foundation has added these emotional wellness checks to move towards a whole child approach, because we know that kids' emotional and mental health is just as important to their overall wellness as their physical health. So the goals of this program are to reduce stigma associated with mental health needs and services, and to improve school attendance and academic performance. And so If we could have the next slide, perfect. And so as we carry on throughout this presentation, I'd love for all of you to reflect on this question. How have you seen the mental health of youth in your life impacted over the last few years? So go ahead and tell us in the chat feature, and I'll share from my perspective as a physician, what I've seen in both the clinical setting as well as what has come through these wellness checks is that mental health is a huge problem for kids in our community. And in my role as a physician who works in the hospital, I often see children when they're in a mental health crisis. And having witnessed many of these really devastating situations, I'm really grateful for this program and its proactive approach to mental health. And thank you, Vice President Susan Ellenberg, for kind of sharing that stigma is declining for mental health. And I'm really excited that we can all be active participants in that. And I'd love to hear from anyone else. There's any other chats I want to come through of how you've seen mental health of youth impacted in the last few years. Perfect. So moving on to the methodology of this program, we'll talk a little bit about just the general stages of how it works. So there are 3 stages for the My Health First wellness checks. So it starts initially with the wellness check itself. The tool that's used is a hybrid between Project Cornerstone's developmental assets and Kaiser's POQ2, which is used in pediatric offices during well check appointments. It includes 3 asset questions and 13 Likert skill questions that focus on the student's strengths, emotions, and thoughts over the last 7 days. The physician verbally asks students the questions. There's a school site staff member there for support, and a Healthier Kids Foundation screener is there to take notes on the student's responses. If a student is struggling significantly, the school site staff, most often a school social worker or counselor, will stay with the student to make sure they are safe and complete the school district's risk response protocol. If a student has unmet needs but isn't an imminent risk, the student may return to class, and a Healthier Kids Foundation parent advocate will follow up with their parent to offer support. And if a student doesn't have unmet needs identified, they may return to class. For all students with needs, parents are contacted by a Healthier Kids Foundation parent advocate who will collaborate with them to identify supportive opportunities for the student and their family. Together, they complete the Pediatric Symptom Checklist, the PSC-35, which is an opportunity to explore needs that families have, as well as their strengths, and to allow an opportunity to connect families with mental health services for their children. And the final step is that the Healthier Kids Foundation may assist with a warm handoff to behavioral health services or other basic resources that families identify they need. After the initial phone call, parent advocates will continue to follow up with families to check in on whether they've been able to access services and resources that they wanted to connect with, and identify any other needs that have come up. And thank you to everyone who's been commenting in the chat. We have some great comments talking about the long wait periods for available psychologists and therapists, that now there's more awareness of anxiety and depression in youth. And sounds like people have family members who are also really navigating a lot of different mental health issues. So thank you everyone for sharing. Continuing on a little bit with who was involved this year for the Wellness Check program, we have an incredible team of people. We have everyone who has been involved. So we've worked collaboratively with 7 school districts, 51 school sites, conducted wellness checks over 67 screening days. We worked with 14 contracted physicians, 58 school social workers, counselors, and providers, and 8 Healthier Kids Foundation screeners. So it takes a huge team of people to allow these wellness checks to happen. And so here's some of the examples of questions the wellness check includes. So oftentimes we'll start with the asset question, and then we'll include questions on how many days in the last 7 days did you feel different emotions, including I felt sad and I felt alone. And students have an opportunity to answer these questions using the spectrum of smiley faces that you see. The Healthier Kids Foundation piloted these wellness checks during the 2021 school year with Franklin McKinley. And at that time, students were remote learning, so the wellness checks took place over Zoom. So here you can see the breakdown of need identified for the 375 students who participated in the pilot. And at that time, of that number of students, 37% had an unmet need and 5% were identified with imminent risk. And so thanks to the great outcomes of the pilot and tremendous collaboration with school districts, the program expanded significantly to 6 additional districts this school year. 2,582 students have participated in the wellness checks during the school year, and a shocking 42% were identified as having unmet needs to varying degrees, with 2% in the eminent risk. While 2% being in eminent risk may not sound significant at first, I want to be clear that this represents 58 students who are in crisis at the time of screening. It is quite possible that without this screening, these students' unmet needs would have remained unknown to the school district and unmet. And there were 3 occasions this school year that Uplift's mobile crisis unit was used in stabilizing a student who was found to be in crisis during their wellness check. And I also want to use this opportunity to once again thank all the school districts who have been incredible partners in this program. Now I want to turn it over to my colleague, Brenda Salcedo, to share some insights from Franklin McKinley School District.
Thank you. My name is Brenda Salcedo, and I'm an administrator and licensed clinical social worker for the Franklin McKinley School District. We have had the pleasure of working closely with Kathleen King and her team at the Healthier Kids Foundation on the My Health First program. As previously mentioned, we piloted this program in the 2021 school year when students were mostly learning from home. Although we hadn't originally intended to conduct the screenings by Zoom, we quickly pivoted and implemented additional measures to ensure the safety and well-being of our students completing the screening. We continued this school year with the screenings in person across the district. This program highlighted our continued work to create strong school communities and safe spaces on campus to address mental health needs, which also includes the increase in school social workers and wellness centers district-wide. It is vitally important that all students have a trusted adult on campus, someone they can go to when they need additional support. Our team has been intentional through presentations, individual and group sessions to address this identified need. This program also allowed us to highlight the need for mental health services across our school community, especially during the pandemic. We were able to host webinars detailing the program to parents and sent various communications to them regarding the screening process. This work is aligned with our district's goal of focusing on the needs and well-being of our school community. In connection with this work, May is Mental Health Awareness Month, and our district is conducting activities throughout the month with the intention of reducing the stigma and normalizing support for those in need. Thank you. Now I'll turn it back to Dr. Adyan.
Thank you so much, Brenda, for sharing all your insights and for all the incredible work that Franklin McKinley School District has been doing. I loved all the things that you've shared about helping students know that they have a trusted adult on campus, and for all the work that you've been doing to help create a really strong school community and safe spaces at school for kids and their families. Next, I'd like to invite Dr. Anya Artigues from Alum Rock Union School District to share some insights as well.
Good afternoon, everyone. My name is Dr. Anya Artigues, and I work for Alum Rock School District as the coordinator of mental wellness support services. I just wanted to start off by just talking a little bit about the fact that, our students here at Alum Rock have historically benefited from our partnership with the Healthier Kids Foundation. So when Kathleen and Laura gave me a call and asked me if I wanted to participate, I think before they even finished a sentence, I was already saying yes. So just to have you understand a little bit about what the needs look like here in Alum Rock, in the time I've worked in Alum Rock, I've actually worked for most of it at school sites, many years, about 10 years as a school counselor, and then several years after that as a school administrator. And one of the things that was always a struggle for me as a middle school counselor was not knowing or understanding what our incoming sixth graders were going to be walking into the door with. I already would have systems in place and supports in place for our 7th and 8th grade students, but because the sixth graders on some level were a mystery, I would find myself waiting until the end of first quarter to find out who I was going to start with first based off of data that I was looking at. We were able to gather data from teachers who had the students prior, but there's a very big difference, which I'm sure Brenda can speak to as well, between the lens of a teacher versus the lens of a counselor or social worker. And so oftentimes, even though we would get some information, the information that we would receive would be more academically focused or more behaviorally focused without an understanding of root cause. And so for us, a lot of times when we'd receive our students, there would be these missing pieces that we needed to understand to better serve them. So participating in this, in the wellness checks as we did, I'm going to tell you that the amount of information we were able to take away and the amount of understanding we were able to begin to build regarding what our students needed, like increased exponentially from day to day to day. It allowed us not just to understand what the needs were, but allowed us to understand and service them in real time, which as a counselor or a school administrator, you understand that getting things done in real time, sometimes if you're doing that for one student or two students, the rest of the students you're not able to work with. But because we were working in partnership with a large group, we were actually able to successfully sit down with every single one of our students and find out what was really taking place for them, therefore enabling us to be able to build out supports that would be relevant in terms of what they needed. The other thing I think for us that was a benefit was it allowed us not just to serve students, it allowed us to also serve families. As we were working with students who were presenting as imminent risk or unmet need, what we were starting to find was that a real toll had been taken on the kids and families during the course of the pandemic. And we were able to help students who were having safety issues around ideation, around self-harm. We were also able to help students who were struggling from isolation because they'd begun to question gender identity. And also we were able to help students and families get safety for themselves from situations that had been taking place during the course of the pandemic that were actually continuing into present day. All of this, in short, allowed us to take the necessary steps in partnership with the Healthier Kids Foundation and allowed us to be able to meet the need at that point in time and moving forward. We were also able to establish a continuum of care between the Healthier Kids Foundation, ourselves, and our SLS coordinators. And I have to say that without this partnership, and Laura can speak to the percentages more than I can at this point, but without this partnership, approximately 30% of our kids would not have been able to receive the support and the services that they so desperately needed that we didn't know about until we did these wellness checks. And so again, very thankful for the partnership with the Healthier Kids Foundation. Look forward to continued partnership and maybe growing grade levels or two moving forward. Thank you so much.
Awesome. Thank you so much, Anya, for your wonderful perspectives and for all of your hard work in this program. So to talk a little bit about a really, really important part of our team, our parent advocates, we have a diverse team of 12 parent advocates who provide support to all students who have unmet needs identified. The parent advocate team is multilingual and has a shared cultural understanding of the families in our program. They conducted the initial parent support call and worked with the parent to complete the PSC 35 and discuss potential opportunities for support. Parent advocates work closely with school district staff and establish wellness centers. They make sure parents connect to appropriate supportive services and continue to follow up to ensure that resources have been accessed. Parent advocates were able to reach 685 out of the 1,144 students with unmet needs. Each call takes about 1 hour to complete. They assisted with 91 referrals to behavioral health and 262 referrals to basic needs services. They're continuing their follow-up with parents who have yet to be reached. And to really emphasize the degree of support that parent advocates offer, on average, a parent advocate contacts each family 6 times before closing the case, with some cases having as many as 27 contacts, which is an incredible amount of dedication. And here's a breakdown of the referrals made by category. 32% were behavioral health, 18% food services, 17% parenting tips, 12% diapers, 5% housing, 4% financial assistance, and many more. And now I want to turn it over to Claudia Colindres, parent advocate with Healthier Kids Foundation, to share what families have been experiencing.
Thank you, Doctor. Good morning. My name is Claudia. I'm a parent advocate at Healthier Kids Foundation. My team and I, we follow with the parent of the student where identify having needs through the wellness check. Our goal is to help them to get some supportive services. When we made the first phone call, my first step is to try to build a trusting relationship with the parents. It is For me, I think it's a very sensitive and delicate conversation to be having with parents about the child. And as a person, I never meet them. So for me, trust is very important when I call them. Once it is established, parents are often willing to open and share what has been going on. Some of the things we hear from there is their students are struggling with bullying at school. Some they have challenged family circumstances like a parent is separating or parent on jail or something. Now, fortunately, they lose a family member related for the pandemic. Sometimes parents don't understand mental health and what is important. So I think the parenting, the child can be sick only they have fever or they have cough or something like this, but they don't know what is really mental health. So for my team and I, it's a great opportunity to reinforce the need to kids to have somebody to talk to them, like a parent or other trusted adult, like a counselor or therapist. I have a case. I remember I cried with this. I cried many times, but with this special case, when I read the wellness check of the child, he say he was feeling sad because he lost his best friend. So when I had the conversation with the mother, I say, well, I'm calling you because I'm concerning for that. And she started to cry and then told me, oh, his best friend was my dad. So my dad died from COVID, and now the child was very depressed because he missed his grandpa. So in this case, we talk with the school and they start to having conversation not only with the child, is with all the family because they have a lot of family member. Sometimes parents know the child is struggling with, they don't know what to do. I recently spoke with a mother about the child wellness check. She already knew that her daughter was having some problem and she needs support. She shared with me her fifth grade daughter was having suicidal thoughts and ideation. She had no idea where to turn, what to talk to, or what to do. So my call about the screening result was his parent starting point to getting help for the child. I am just so glad we weren't too late to help her daughter. She's now getting support she needs. I'm a personalist as a mother, and I got a call like this about my child. I will be so grateful to know that there are programs that help children and parents to be understand the mental problem of our children. And my team and I, we are so proud to be part of this team. I'm so happy to work with this family because our simple call can make the difference in this family. Sometimes they don't understand what is happening with the child. They don't know what they talk to them. They only say, my child wants to be alone. My child doesn't want to talk to us. And when we start to talk, the parents say, oh, I think what's normal. And something is not normal. I have a mother, she told me, oh, my daughter told me the kid at school is hitting her. And I say, oh, did you talk with the school? Oh, no, in my country, that's normal. And I say, no, here. So I'm very thankful to be here and meet you today. And I'm very proud to be part of this team. Thank you so much.
Thank you so much, Claudia, for sharing all of your experiences and your incredible hard work. We are so grateful for all the work that you and your team do as the backbone of this program. So thank you. I feel like that almost moved me to tears. So I think with our final thoughts, we've collected feedback from participants across the board, students, parents, district leadership, school site support, and physicians. And we've gotten feedback that's ranged from predominantly positive to some wise suggestions for enhancements and improvements. There wasn't any feedback that suggested the program was not needed or should be discontinued, and it was quite the opposite. District personnel felt it was highly effective, and parents saw the value and wanted it to continue. We, of course, are always learning and want to share some of our learnings, limitations, and improvement themes that came up. We're working to improve standardization and more thorough preparation for teachers, school personnel, parents, and students in advance of the screenings. There were specific recommendations for how to adapt the screening process and how to provide immediate support for children identified through the screenings. Continued focus on cultural awareness, humility, and anti-racism trainings for all the people who participate in the program. And I think I would be remiss not to say that we always acknowledge our own perspective in developing this project as one that is impacted by our own privilege in this space. And there may be blind spots that we're not aware of. And we're continuing to work hard to make improvements, and we're really eager to hear all of you if there's any thoughts or ideas that come up from this presentation. And as for what comes next, we intend to improve the program through our many learnings, and with funding permitting, intend to implement it with additional grades, hopefully during the 2022-2023 school year. And we're about to go into questions, so please make sure to add yours to the Q&A. And before we do, I want to end on a brief quote from a parent whose child participated in the wellness checks. From this parent: "My son used to be so nervous and afraid to communicate what he was feeling. Since receiving support, I've noticed he is slowly opening up to me. I feel like the sessions with the therapist are working. This has been such a great experience for me. I wish all students could receive this service." Thank you, and we will move on to your questions.
Hi, everyone. My name is Laura Clendaniel. I'm the VP of Operations with Healthier Kids Foundation, here to help facilitate the Q&A, but unfortunately we're running a little bit behind and we want to keep ourselves moving on schedule. We do want to get to your important questions, so if you add your questions to the chat or the Q&A feature, we'll be sure to respond to those, and we'll type out our responses. In the meantime, I do have one question for Anya and for Brenda, which is, if it came from the Q&A feature, if I were to bring a program like this to my school district, what pieces do you feel are critical to have in place before launching? So Brenda and Anya, I'd love your perspective on that.
For us, this is Franklin McKinley School District. I think it's really important to have a well-developed district crisis protocol and to include a mental health specialist. In our district, we use school social workers. So it's really imperative that they be included and know how to respond in case the student requires a higher level of care and Pacific Clinic's mobile crisis needs to be contacted. Yeah, thank you.
Thank you. And I would say the same. The crisis protocol is integral because everyone has to be on the same page in terms of how to respond, upon crisis taking place. The other thing would be, for us, what we found worked was having a team of specialists. So where Franklin McKinley has social workers, we have school counselors. And what we did was we made sure that we had 2 or 3 school counselors in place at every school as we were going through the process. That way, if a student would go into crisis, we were still able to continue supporting and working with the remaining students.
Wonderful. Thank you for those responses. Again, we want to get to all of your questions. Please add them to the Q&A feature. But with that, I am going to turn it back over to Kathleen. Claudia, Brenda, Anya, and Anu have been critical to implementing this program from the pilot phase to the expansion into other school districts. I know I have many of our partners from other school districts with us today as well. So thank you all for your great contribution to bringing this program to fruition. Kathleen, back to you.
Thank you, Laura. It's quite amazing what a group of dedicated people can do to go from 475 one year to 2582 the next year, and to help children that just are feeling the stresses that they're feeling right now. So thank you to our partners. Thank you to Laura and her team and the screening team. I am going to turn it over to Tasia, a 9th grade student and member of Congresswoman Anna Ishue's Student Advisory Board, to introduce the next speaker and presentation. Please stick around. Dr. Myers is fascinating. Thank you all. Your turn.
Hi, everyone. My name is Sriteja, and I'm in 9th grade. I am excited to introduce Dr. Dowell Myers, who will be presenting Children and the Future, What the Trends Are Telling Us Now. Dowell Myers is a professor of policy, planning, and demography in the Sol Price School of Public Policy at the University of Southern California. He specializes in how demographic trends interact with all areas of policy and planning. Recent research has focused on the doubled importance of children in the post-Great Recession era. The intergenerational relations among aging baby boomers, immigrants, and diverse youth were the basis of his award-winning book, Immigrants and Boomers, Forging a New Social Contract for the Future of America. Myers holds its PhD from MIT, following degrees from UC Berkeley and Columbia University. Thank you.
Dr. Myers, are you there somewhere? There you are.
I was going to say, we're having a little bit of technical difficulties, but he should be on in a moment, and there he is.
I'm here. Sorry.
All good. We are on to you.
The sound went out. Do you want me to share my screen now?
Yes, that would be wonderful. You're good.
Okay.
We can see you. We can hear you.
There we go. All right.
Here we go. Now we can see it. Thank you.
Greetings, everybody. I'm so sorry for that slight delay there. I hope you all hear me now. If not, let me know. I'm really pleased to be invited to speak once more at the Healthier Kids Foundation Summit, the annual symposium. I did it, I guess, back in 2019. That's ancient history. That's before the pandemic, right? So we're starting fresh here. So the latest trends are really, well, the Census Bureau's census has been delayed, and they're not going to be releasing the real data until 2023 now because of the pandemic. But I have some other forecast information and birth data, and I want to talk about the status of women, of mothers also. That's in the news, and it's all related. So here's the basic topics I got for you today. I'm going to rush through these pretty quickly about the downturn in babies. I get the most media calls on that, and I'll show you a big CBS report that was done in the middle of my talk here. But it also has immense pressures on young parents, and I think that's overlooked. It's also overlooked how important the children are, that we cultivate all our children to be the very best they can be to their fullest capabilities. We've been neglecting kids, still neglecting kids, even though we desperately need them. They're twice as important now as they were before. Statistically, I can show you that. So let me just move forward. This is the big picture of from 1910 to 2020, 110 years of the ups and downs of births. And I just want to point out a few things. The black line here is the number of babies born. And it's been about roughly 4 million a year in the US. And below there is the birth rate. But we'll look at the number born. Here's the Great Depression. You see how there's a big dip here in the birth rate and the number. And then it went up in the baby boom. We all know about the baby boom. I'm a member of the baby boom. It's an 18 years wide generation marching forward in time. Here's Gen X, which is a small generation and created lots of problems because it was so small, because that was followed by the millennials. Peak millennials, 1990, born in 1990. There was a 32% increase in number of babies born, which means 25 years later, there's a big increase in people age 25. And that's smacking us in the housing market right now. It's a big driver behind this incredible shortage we have. And then Gen Z is falling behind that. So that's just the big picture of things, but I want to look in more detail because births are just births, but they reflect mothers directly. And mothers have a social status, and it changes with the birth rate and what are they doing with their time. And it's very important. But it also, the numbers of babies born has impacts on public policy. So our demographic data in California is all kept by the Department of Finance because the number of babies born, number of people in school, number of taxpayers, all that is crucial to the planning the future of the state's economy. So they track it very closely under the governor's office. I want to show you how it's changed so drastically in California. And a lot of our politics are based on the past because we don't realize how things have changed. This is the number of babies born each year from like 1970 up to 1990. And at that rate, you can tell it's going to go through the ceiling. And people reacted like it was. And they were very fearful of this being overrun by all these babies. We just can't possibly afford all these children. And they're not, who invited them in the first place? We really don't want all this. And a lot of reaction is against that. Subsequently, the number of babies born actually turned downward. There was a brief rise here in the boom period before the Great Recession, and it dropped in the Great Recession. It started to revive, and it's been diving again. And why it's diving again is after 2016. I don't know how time to discuss it or not, but there's a lot of despair, or barometer of despair, I call it, involved in babies going down. People have kids when they're hopeful about the future, when they feel that there's anxiety or uncertainty and there's conflict and rancor and discord, not so welcoming of new children. So we don't really support our mothers enough. Here's what they expected was going to happen. The forecast in 2007, here they are over here. These are I'm going to show you a series of forecasts. They thought, okay, after the Great Recession, baby making is going to rebound and we're going to be back on track again. And they were still worried about how it might go too high. Well, that was then. Then later they tried it again in 2012 after the recession, and they thought it's going to revive, it's going to go up. Well, that didn't work so well. So now then a newer projection in 2017 said, well, I think it's going to keep sloping down slowly. And the most recent projection as well, it's definitely slower. They don't see any upturn. Going out to 2040, there's really no upturn. So we actually have fewer kids now, 30% fewer in 2030 and now than we had back in 1990. So we're way down. Now we're fearing a shortage, and I'll show you some details on that in a minute. It's a big problem that we don't have enough kids. We need more kids, and we need all our kids to be the best they can be, since we have to make the most out of the kids we have. So the changing birth rate, it's falling for all groups. And I have some details here and some explanations. I'm not going to run through this right this second. I'll leave the slides for you to look at. But there's a change in economy. People have longer education. The key point is that women's time is intensely competed for in this age range right here. You all know that, between 20 to 39. People are trying to establish their education, complete their higher education, because the knowledge-based economy sort of demands more education. They're trying to get their careers established. They may want to have kids in this window of time, you got to get it done. And they may be trying to buy a house. And in California, that's really hard to do. So all this happens in a very compressed time, and it all falls on women's shoulders, I think. It should be falling more broadly, but at least the society should help out more. I make that case repeatedly. I'll talk about that more later. Here's the actual brand new report from the Census Bureau showing the birth rate by age. Here's the teenagers, and it's fallen a lot. We're looking at from 1990 here all the way down to 2019, the most recent data. And this is the annual data. You see how the birth rate fell. It just inched its way downward steadily. And then there was a gap right here where it leaped to 2010 and then fell more. And that leap in there is the pause in the Great Recession, where, and then we came out of the Great Recession and it's never gotten back on track. It just skipped forward in time dramatically. What's happened is that people are delaying having babies until later, out to age into the early 30s. As I'll show you in a minute, the median age for having a baby now is 30 years old. That's the median in the nation. And it's a little higher than that in California. So let me just skip forward. We have some details on the same age pattern here from the same report, looking at it between native born and foreign born. The point here is it's dropping for all groups you can look at. So these are foreign born, they had the highest fertility, and now they're down to this orange line. And the native born were the light blue, and they fell to the blue line. It's just collapsing at this young ages for everybody. And then here it is for Latinos and non-Latinos, or Latinas, non-Latinas, and it's dropping sharply for them as well. And then here it is for whites and blacks, and it's dropping his blacks line here in 1990, then it fell to the orange line in 2019. It dropped more for blacks than it did for whites, but it's dropping for everybody. There's nobody who's having too many kids anymore. Nobody's having enough kids anymore. We need all the kids we can get, and we need to share it broadly because every kid is important to everybody else. Although they're expensive, and so some people are kind of grumpy about it, and they don't want to be paying for kids to go to school. They don't want to pay for services. They don't think they need it because they're elderly and they've already been through that stage themselves, and they just assume push it off. And I'll try to disabuse you of that assumption coming up here. I know you already believe me, but I'll disabuse you anyway. Here's the United States data, just summarizing between 1990 and 2019. You see the big drop in the US, you see what the new birth rates are. Here's the actual change in number of babies born in the 20s, in people's 20s, and then very little we actually make up later on. It doesn't really, they get postponed a little bit, but not much. And I'll show you California in comparison. And I'm just going to tell you, we have a bigger drop here. So I'll compare that directly for you on one slide. Here it is. Here's the California drop. It's about twice as big a drop as there is in the US for women in their 20s. And then later on, there's a little less catch up in California. I think people are struggling at this age right here, trying to figure out how to buy a house, and they have to take time off from work to have a kid, and the mortgage is coming due, and every month there's a mortgage, and so people get locked in, and they may not have time to have a baby. It's really a problem. The replacement level, the break-even level, I call it, is 2.1 babies per woman on average, and the U.S. was right at there back in 1990. California was above that. We did have more kids than typical, but only 2.5. And now we dropped the most. And so we're below the US. And that's the picture there. I think it's because of housing prices. That's my main assumption right now for the difference between us and the US. Immense pressures on young parents. It's really, that's really a problem. I'd like to show this slide. You can look at that later. Here's an interesting thing. What are women doing with their time in their 20s? If they're not having kids, what are they doing? Well, they're going to school. This is the people ages 22 to 24. This is after high school. This is after getting a BA degree even. These are people getting advanced training. We're looking for 1959 to 2020. And you see that it used to be that men got advanced training and not women. But the women's line has just risen steadily. And now they've passed the men, and they're more enrolled in advanced training than men are. And it's a third of women in the US. In California, it may be higher. I don't have exactly this data for California, but it shows you that there's not a vacuum there in age 20 to 29. That's a period when people become independent of their families where they grew up, and where they develop their social identity, they develop their career identity, and it's an important time for people to live an independent lifestyle without being burdened by children, without being burdened by some partner, and they find the right partner, and then they live their lives on after that. So this time's being well used in exploration as part of the modern economy and the modern society. Here's the median age is advancing. Even for foreign-born, it's gone from 27 years to 32 years for foreign-born women, the age at which they have kids. So it's pretty much every group has delayed this, having kids, and they're all enjoying this period in their 20s where they can explore for themselves and develop independent lifestyles and careers. So I think it's a positive thing. But all that pressure is coming on the parents, the young parents. So Laura, we have a video. Is that queued up and ready to show, the one with Walter Cronkite and other luminaries?
Yes, give me just a moment.
This is from CBS News, and Walter Cronkite was the longtime mainstay. He's famous, legendary if you haven't seen him. So he'll come on in a second.
Which one full year of COVID restrictions, there's new data confirming that a baby boom that some doctors and, for that matter, comedians expected is actually turning out to be a major baby bust. Health departments in 27 states provided records to CBSNews.com, and they show a 7% drop in births in December. That would be 9 months after the first lockdowns began, and it could be just the beginning. Researchers say it matches a much bigger plunge in fertility that is decades in the making. The number of babies the average woman is expected to deliver in her lifetime has dropped from nearly 4 in the 1950s to less than 2 today. And that could present an entirely different threat to society as we know it than we were first warned about decades ago.
The stakes in this battle are far greater than any other we have ever fought.
In the 1960s and 70s, an apocalyptic fear gripped America.
The experts we interviewed told us population was the fundamental crisis.
As the world stampeded toward 10 billion people, many researchers predicted that overpopulation would ruin us.
Sometime in the next 15 years, the end will come. And by the end, I mean an utter breakdown of the capacity of the planet to support humanity.
But these days, a very different note from researchers like USC professor Dow Myers, who studies demographic trends.
The trouble is that we overshot. We dropped it down too much now.
While the global population is still growing, a major study last summer predicted it'll actually peak in 2064 and then fall by nearly 1 billion people by the end of the century. The reason? Fewer babies. Here in the U.S., in fact, we're already below the so-called replacement level by some measures. And that means fewer young people to support our otherwise aging population.
That's a crisis. We need to have enough working age people to carry the load of these seniors who deserve their retirement. They deserve all their entitlements, and they're going to live out another 30 years. Nobody in the history of the globe has had so many older people to deal with.
And the pandemic is only making this problem worse, despite some early jokes that more families staying home together might mean more babies.
We thought, oh, we would see a baby boom, but we just haven't seen it.
Dr. David Jaspin is chair of the Department of Gynecology and Obstetrics at Einstein Medical Center in Philadelphia. He says patients are worried about not only their health, but their finances.
So you're hearing more people ask you about contraception and fewer people say, we're thinking about trying.
That's absolutely true. I get a report every morning at 5:15 about what has happened in the last 24 hours. And the first report that I see is the number of deliveries in the last 24 hours. It's less than it used to be.
The question now is, how low will it go? The Brookings Institution has predicted a large, lasting baby bust of at least 300,000 fewer children in 2021.
We are on the precipice, at the very least, of not having enough children to replace our population.
And so what? I mean,
well, that's the interesting question. Yeah.
Right? So
Laura Lindberg tracks reproductive data for the Guttmacher Institute. And while she's also seeing the baby bust, she views it as a sign of progress, a marker of women's equality and freedom of choice.
So it's a shift to later in life. In that shift comes more education, more career, more employment. So it's a reordering of how people engage in adulthood.
Dow Myers doesn't disagree, but in the bigger picture, he worries our declining birth rate is also a barometer of despair.
In 1978, when you were breaking into the field, did you ever think in your lifetime you'd be talking about a declining birth rate globally?
No.
So what changed?
The burdens of life, the cost of housing, the cost of education, all these things have become more and more difficult. I think the boomers themselves don't realize it, how much harder it is for millennials today. And they think, oh yeah, when we were young, we had to live, on very little money, and we made do, and you can do the same. That's the story, right? Well, no, it really is a lot harder for the young people today. It's amazing how much harder it is.
Yeah.
See how I slipped in that millennial propaganda?
Yes.
But I think that's true, though.
Yeah, but it's a very important point, I think.
Yeah. So on the one hand, it is a story of equality and choice, but there are people out there who want to have kids but don't feel they can because their finances are a mess, or they have huge college loan debt, or they can't afford a home, or childcare is crazy.
So it sounds like it was strictly finances, but do you think part of it is you're at home and you're just really getting on each other's nerves?
Well, yeah, so yeah, everybody, there's also
I
studies
just
out
don't
there.
like you right now.
Everybody's having less sex right now, single people included, but the people who are having the least sex are people with children. Every night, actually, in my home, we have to clean the kitchen, and there's a big window, and Katie's always joking that we're putting on an advertisement for safe sex, because as we picked baby spills off the floor, the Swiffer all night long like this, the crayon markings on the fireplace.
You may be putting in an advertisement for safe sex, but there is a baby coming. There's a baby.
There is a baby
couple
coming. Yeah,
You are the outlier.
Department of Justice. Go ahead.
Yeah. So I hope you enjoyed all those luminaries. Laura Lindberg is a serious family planning demographer, and she played her part really well in a snowstorm in New York, and I got to be in California in the sunshine in the park. I had no idea what was going to happen there, the way they scripted that and put it together. But here's a link here on it. You can look at this later if you want to see this link.
it's on the slideshow as well. So let me move on to the doubled importance of children in an aging society. We've got some just really basic facts here to look at. First off, people just don't realize how lopsided we are, top heavy. Here's the growth of adults, percentage growth since 2000 in all the states. And you see California, the golden state there, is close to the US average, a little higher than US average in terms of our growth of adults. But when it comes to kids, nobody is growing as fast in kids as they are in adults. And California is actually negative and dropping more negative now. We're losing kids in absolute numbers. So it's something to deal with because that means that's our future workers and future taxpayers, and we have a lot of older people. So I have a ratio to try to show that. First, I'm going to give you here's the growth by age group. This is the growth from 1990 to 2010. I think people always look back to the recent past as being normal. So recent past was, we had a heck of a lot of growth in this age range right here. This is the late middle age, executive homes, executives, not a lot of young people. Here the millennials out here are still kids, and not a lot of growth of old people. So this is like really the sweet spot. These are the highest earners, highest taxpayers, and we did that already. So we're going to see the next decade or the next 2 decades where we are right now. By 2030, all the growth here is over age 65, because these are the millennials and they got older. Sorry, the boomers. The millennials are down here, and it's a pretty small little bump because I think we should have more, but we lost some of them because they left because of high housing prices, or they chose not to come to California. So we don't have any growth here in kids, and a whole lot of growth in older people. So that's the reality we're facing. And all the taxation, fiscal structures have to work on that. And they're going to tend to want to put all the money on the old people because that's where it's growing. But I maintain that the people that aren't growing down here, we have to cultivate twice as much, because everybody has to carry twice the load. If you're a child and grow up in California, you have to do twice as much. So you need twice the preparation. And it shouldn't be paid by your family. The state should pay that at higher ed. So here's my ratio, the senior ratio, I call it. It's simply the ratio of seniors divided by working age. And it traditionally has 24 seniors per 100 working age. And here's the actual trends. It was flat from 1970 to 2010, very constant. And so no one paying attention to it. Why was it flat? Well, the first baby boomer didn't cross age 65 until 2011. And then the skyrocket took off after that. It's just simple math. So we got used to it not being an issue. It wasn't an issue. And now it's a total issue, and still haven't reacted to it. No presidential administration wants to take ownership of this because they can't stop it. Politicians don't like to mention things that they don't have a solution for. No one can stop aging. I have a solution though. It's not that you don't try to stop aging, you got to cultivate your base. And the base is these young people who are going to be lifting up twice the load, literally twice as many people on their shoulders as before. And so every kid is twice as valuable and precious, and we need to put twice as much investment into them as before. California is even a little more extreme. Here's Santa Clara down here. It's like Orange County, formerly a bedroom suburb, lots of kids, not a lot of old people, and now becoming, Orange County is the worst. I mean, they think they're going to be Santa Barbara up there. No one can afford to live up there, live down there. It's too expensive. It's a nice place to live, but there's no kids and no young people, no nightlife in Orange County. And so it's really changing the whole social complexion of our state. And there's not a lot we can do about that, but we can sure fortify the base. That's all I can keep repeating. So I just want to show you one more thing. It's really kind of unknown. Where did all these kids come from? Are these all immigrants that came in here, or are these from other states or other countries, or where do they come from? Well, this is the breakdown in 2016. It's a little bit higher now, but it was in 2000 that we first crossed this line, 50% line. Before that, the majority of Californians were not born in California. We were slow to get there. Since the time of the gold rush, people always came from other states, other nations. But we've crossed that line in total here. But let me show you by age group. For young people, like under age 5, 95% are born in California. There's no foreign-born kids, very few. And they may have immigrant parents, but immigrants count for almost half of the babies we do have born. Almost half of them have an immigrant parent. But remember, we're below replacement level already with our kids. If you took away the immigrant half of the parents, we'd really be in deep trouble. So we're thankful that we had that. In the US, it's about 25% of parents are immigrants. So without them, the immigrant contribution, we'd be in deep trouble. We're already in deep trouble, but I don't know, we'd be unsavable. We'd be like Japan. So here's age 25, 34, which is the most crucial age. That's the engine room of society. That's the new workers, the new taxpayers, the new parents, the new voters. I mean, the 25, 34-year-olds are how you make your future. And they are now majority California born. Very few come from other states. And then here it is looking at older ages, and you see how there's more foreign born actually at age 45 and 55 than there is, and then, well, you get the picture here. I'm almost out of time here. So let me get to my conclusion. You know this conclusion. We need all hands on deck, no dropouts acceptable, college aid, financial aid for anybody who needs it. Early childhood interventions are the best because you get the longest return on your buck, biggest return from that. I borrowed one little sketch here from the At a Glance report. This little about child poverty graph is great. It's on page 6, I think. I took it from. It really cut child poverty way down, but it was temporary. Now we've had to give it back, and people around the world are calling us fools for giving it up because we're snatching defeat from the jaws of victory. They put it at The Economist magazine. I just think we have to remember that kids grow up, and kids are so valuable. They turn to our young adults, and then young adults get to be mature adults. And your role as a mature adult is to pay the most in taxes because you had the peak earnings, and that's your role in life. And you take turns doing this. You're not doing it forever, because then you get to retire and you get all those benefits back. So we take turns, and that's the cycle of life. And we have to remember that intergenerational partnership. My conclusion is simple takeaway. We totally need other people's kids, and we need them to grow into their fullest capabilities possible. And we should start from the youngest age so that we can have the greatest impact on the future of us all. Simple as that. Thank you.
Thank you, Dal. As usual, it's amazing how you get to the point. And I love that point as one of those baby boomers would love grandbabies instead of grandpuppies. I told you we have to have our young people have more grandbabies. And thank you very much. And we come to the conclusion of our program. We want to thank the presenters, the sponsors, the attendees, and especially the staff that put so much work into this, and our partners that also spoke. Thank you all. Make sure you complete the survey that's in the chat. And if you don't get a chance, I'm sure we'll send it out to you, and we really appreciate the feedback. We ran out of time for a lot of the questions, but if you do give us questions afterwards, we will make sure they get answered by the presenters. Thank you very much, and have a great rest of your day. Enjoy it with gratitude and pay it forward. Thank you. Thank you, Dal.
Thank you, Kathleen.
Go back